Good morning and welcome to the HHS Committee. I am grateful to be joined by my colleagues, council members Don Lutke Friedson and our guest, council member Mink. So we have 3 items on today's agenda. And so we are going to be starting first with a special appropriation, a supplemental appropriation to SEF. And I'm going to turn things over to Tara to brief us on this supplemental appropriation for FY26, and then we will go through the remainder of the budget. We will go back to item 1. So we're starting with item 2. We will go back to item 1, and then we will end with a deep dive into quite a few items with the Department of Health and Human Services. And then we have some items that were recommended by colleagues, and we will touch on those in item 3. Anything else to add, Tara? All right, let's get started. Thank you.
Good morning, and thank you, Chair Sells, and good morning to the rest of the members of the committee and our guest here from DHHS. Just to set the scene, as Chair Sells said, we have about 30 items that require the vote of the committee today. If not, we will have to have a follow-up work session on April 27th. So our goal is to ensure the committee can move through the items and so that they can be voted on at full council. We are starting with item number 2, the supplemental appropriation 26-14 for services to end and prevent homelessness for emergency family shelter services in the amount of $3,064,158. The main items that this supplemental covers are support for overflow motel sheltering, approximately 85 rooms, and $2.9 million that will sustain SEF through the end of the fiscal year and help to house families. There is $50,000 requested to cover maintenance costs associated with the use of those facilities and utilizing those facilities long term. There are just maintenance issues that occur that are not budgeted for currently within using overflow motels. And the third item is for the Stepping Stones Family Shelter to move its operating to 100% capacity, but the budget only covers 70% capacity. The Stepping Stones Family Shelter operates under a open solicitation, and so when they applied and were awarded the funds, it was the expectation that we would only need 70% of the capacity, but that has changed due to the need in the community. So the $54,000 is requested for up until the end of the fiscal year, and SEF has informed us that additional funding might be needed in FY27 to support 100% capacity as well. But right now, that has not been part of the FY27 budget. So I will stop there and see if there are any questions for me and go back to the committee. Thank you.
No questions. I'll turn things over to HHS. Dr. Bridgers.
So good morning, everyone. Councilmember Friedson, Councilmember Lukey, and our honorary member, Councilmember Mink. Thank you for joining all of the sessions, day 5 of day 6. How about that? There's a lot to discuss today. Before I turn it over to Chief Hong, just wanted to say this. We appreciate all of the efforts and the input on the CE's recommended budget. We appreciate the candid, sometimes tough discussions that we've had with the committee. We have a lot of our community partners behind us, and I want to thank them for all of the input, the feedback as key stakeholders as we continue to move forward in supporting our underserved and at-risk communities. A lot of tough conversations have been had, and we know that we need to do more work in this space, either for sustaining our programs, evaluating the program effectiveness, and just the overall impact in the community. So thank you, community partners, for your ongoing support to HHS and our committee. As I like to end and begin, we will get there together. I'll turn it over to Chief Hung now.
Thank you, Dr. Bridgers. Thank you. So this, because as you all know, the number of families we've seen in particular in our county has And we were able to do really incredible work with the SHARP program, and we'll be sharing data on that and our successes in our presentation after this. And we continue to see families presenting in need of shelter. And so when our permanent shelters, and we have 3 of them, are full, we still rely on our motel budget to place them temporarily in motels as shelter. And I do want to state that although the supplemental will increase our funding for this year to $3.87 million, we spent $4.71 million last year. So that is still a decrease from last year. And with the outcomes that we'll be sharing shortly with about the SHARP program, we expect that decrease to continue into FY27 on our motel expenditures. We currently have close to 60 families in our motels. That is far less than what we've been seeing for most of FY26. And so though this is really needed, we expect to need less as the years progress, especially with the success of the SHARP program.
All right, did we want to?
If there is any discussion, if is needed, but please let me know how you would like to proceed.
Yes, so Councilmember Friedson has a question.
Yeah, I did just want to talk. I mean, I think there have been successes in the SHARP program. I've been a big supporter of the SHARP program. I am a little bit concerned, and we've heard from a wide variety of viewpoints across the spectrum of those who are involved in this work, the concern of whether or not we really do have a housing first model, and if we're focusing too much on sheltering and not enough on SHARP. And I just would like to talk about that a little bit. I mean, I'm going to support the supplemental because I just don't know how we get out of this right now, but I don't think it's clear to me, and I certainly don't think, based on conversations, that it's clear to those who are partners in doing the work in the community of what our strategy is to move away from sheltering to the extent possible. Sheltering should be, last resort emergency situation. It's like sending a patient to the emergency room. We have to have an emergency room because emergencies happen, but it's not a healthcare strategy because emergency rooms don't keep people healthy. They respond to crisis. To address people who are experiencing homelessness in a chronic way. So if you could just share with us the strategy, not to say that we're doing some really good work in SHARP, which I think we are, but how do we shift our focus, our strategy, our resources out of what feels like a lot of sheltering into permanent supportive housing, SHARP program, or other similar programs like that?
Question that gets to our strategy of making sure that we are focusing first and foremost on housing people when they experience homelessness. And to do that, which our data will show, we do have to have an adequate supply of housing resources. And prior to SHARP for families, we didn't have enough. And that's why when we saw the alarming increase in family homelessness, why we needed a resource, a housing resource that would help us to rely less on sheltering, because that is only for the crisis. And you're absolutely right. It should be the last resort and for as short a time as possible. It's incredibly disruptive to families and traumatizing to have to live out of a hotel. It doesn't work. And prior to the SHARP funding, the motels, they were being relied on for longer term shelter. And if you can imagine trying to feed your family in a motel that has a mini fridge and a microwave, it really is not conducive to supporting your family and for children in a family to be able to thrive. So housing is the way to go. And in addition to that, and that we will talk more at length about our housing in the presentation we prepared, we must prevent many more households from entering homelessness. Shelter is the most costly intervention. So prevention and housing, those are the key strategies for Montgomery County to end homelessness. And when a household does enter homelessness, that it is a brief experience so that they can get back into housing as quickly as possible. To the first part of your question, we do embrace a housing first model across our COC programs. It's something that we ask our partners when we have competitive processes, like with the HUD Notice of Funding Opportunity, which has generally been an annual grant and a competitive process. Our partners have to state what they do to have high fidelity to the housing first process, the housing first approach. And that means actively reducing barriers to accessing housing and upholding the choice of the people we serve, whether it's the type of housing, the location in which they choose to be housed. Those are all principles that we follow as a county, and I'm very proud of that, and we will continue to do so. That's what I would say, that those two approaches, and the housing first model, but also housing and prevention, are the most important parts of the work we do. Sheltering is needed because so many people are in crises, and I'm very proud that Montgomery County does not allow families with minor children to be unsheltered. That is a commitment we've followed through on. That's why we have to make supplemental requests when needed. But yeah, I wanted to say why it's needed, why the sheltering is needed.
I appreciate it. I think there's total alignment on philosophy. I still think we need to work on, not just today, but moving forward, the strategy and the execution, because it's still not totally clear to me that we've connected the philosophy that we share and the principle that we share of housing first and the strategy of here's how we actually execute that, here's how we deploy resources and partnerships to make it happen, and then the execution of here's how we prove that we're actually doing it. So it's intended as a reflection of where we are and the frustration that a lot of people in this room and many more people beyond this room have on where things are. We're in a challenging moment right now. The numbers are staggering, and each of those numbers is a person and a family and somebody who is in crisis or is traumatized by a crisis and dealing with that on a daily basis. So I just wanted to note that. I don't think we're going to be able to solve all of these problems during this budget process right now. Unfortunately, I wish we could, but I do think we need to talk about it. And I do think we have a lot of follow-up work that we're going to have to do to move us from philosophy to strategy and then ultimately to execution. So I'll yield back.
Thank you, Councilmember Friedson, and we'll turn things over to Councilmember Mink.
To the spending on emergency shelters as we've increased the spending on SHARP. I know we're going to talk more about SHARP, but that's something that you all and that this council has really leaned into, and it's just great to see that reflected that in the numbers. Each of the numbers is a person, as Councilmember Friedson said, but we're also working within budget constraints, and so seeing that investing in people our budget, as we said it would be, as you said it would be, and being able to see that come back and mean that we have then more resources to put into the space to continue to improve things, is a bright spot in a very difficult situation. So I really appreciate that, and I know that's something that we've also talked about, is that ideally, if we had enough funding in the SHARP space, ideally we would be catching all of these families before they are moved into the shelter in the first place, right? Every person who ends up in a shelter who has experienced being unhoused that's the result of a series of many policy failures. But the SHARP is one example of a way that we will be able to get in front of that eventually. There's a lot of people who are in our shelters, and we've talked about families, but there's also lots of individuals who would benefit from having this opportunity also. And ultimately, this is about what investment we're going to make in the space and what investment we're going to make in all of these folks. And so this funding is really, really critical. But I think it's important that we note that what a good investment this is. This is proven now. So we need to continue to put money here. It's a good investment on many, many levels, and we need to expand the funding. Capitalizing on this success to get in front of that moment where everyone is, where people experience being unhoused, and now we're moving them much faster to get out with this funding. But what we really want to do, I know what you all really want to do, I know what our advocates and our community members want to do, is we want to prevent that experience of being unhoused in the first place, and we have a strategy for doing that. And then we want to make sure that individuals have access to that as well. And I'll note that a lot of times these individuals are our family members, and they're split up into different shelters. So there's, very challenging situations. And so we're at a place where we've been able to really prove dollar for dollar how this is a good fiscal investment on the family side with the comparisons to the emergency shelter money, and that allows us to really show that. It's harder to show that for individuals, and I think that's the challenge there, but I think we must get there, and I think absolutely that analysis is there, because one person, it's not just the expense of a bed. There's so much of a greater cost both to the individual, to the county, to the community, all of those things. We're going to be much better off helping those folks get housed and stay housed, which we know that SHARP allows people to do. So I appreciate this moment to note the success of that program and to look forward to expanding it in these different ways as quickly as we can. Thank you.
All right. And now we have remarks from Councilmember Lutke.
Thank you. And I echo the comments of my colleagues, and I certainly appreciate everything that you all are doing and the success of the SHARP program, right? It is proven and it does work. And noting, as Councilmember Mink did, the need to explore this for beyond the family context, right? Because we've got the prevent part, and then we also have the end part for the folks who haven't gone from a residence to a shelter and who have been unhoused, and that can be a much trickier space to deal with. And I know from our office working with you and your team and other folks within HHS, and I see our folks from Every Mind here, how complex this is, and so I don't want to lose sight of that aspect of it either. But with respect to permanent supportive housing, because SHARP is a temporary period, and then our permanent supportive housing program has a separate set of criteria for eligibility, and also we don't have enough spaces for the demand. So I wanted to put that all out on the table as we ideally we do not want people in hotels or motels for the reasons you stated, and it's just not functional. And when you think about, I said the average length of stay, which means there are variants in either direction, but is 145 days. It's a lot of time. And so I look forward beyond the budget cycle, what the impediments are or the why of why it may last that long, because there are, I'm sure, you can from like a case study perspective say these are the trickiest ones. These are the things that are causing it to take longer for this family, which may be experiencing not just housing insecurity, but many other things. So that we're taking a look at it through that lens, so that we aren't ever talking, and it's very hard because in the HHS space, we really shouldn't ever be talking in a silo. And that we can have that deeper dive discussion post-budget. But I know that this supplemental is incredibly important to get us through the remainder of the fiscal year, and so I appreciate all of your efforts. Thank you.
All right. Thank you to all of my colleagues. As we know, supplementals are for emergency purposes, and this is going to ensure we make it through the rest of the fiscal year. The supplemental appropriation is filling a gap, not just for the unhoused, but those that are fleeing violence, those that are escaping domestic violence alone or with their families. And so I have no objections and know that we will continue to have discussions, and we're actually going to move into a broader discussion about the continuation of SEF and some more information about the coordination of services. And so if this is without objection, we will head on over to item number 1.
Okay, and so I just will note for the record that there was consensus for the committee to approve the supplemental, and that will move on to full council.
Yes, thank you.
We are going to item number 1, as noted by the chair. Item number 1 is a review of the FY27 operating budget for the services to end and prevent homelessness. Thank you to the team for providing the information to support the packet. And I will go through this first page, and then Chair Hong and Dr. Bridgers will have a brief presentation to help introduce the recommended changes and talk about some of the programmatic things that have been happening within SEF. The county executive recommends an increase of $6.2 million or 10% from the FY26 approved operating budget for the department. The executive's recommendation includes $5.5 million in programmatic and staffing additions, enhancements, and other cost increases that are listed below. According to the council president's budget approach, these items will be on the reconciliation list, and the committee will vote to either support the CE's recommendation, or you can recommend any increases or reductions. And going through the items quickly, there is $2 million in one-time additional funding for the short-term housing and resolution program for families. There is $1.9 million recommended in one-time funding for the overflow emergency shelter support for families at a reduced level of motel usage due to funding added to SHARP. $1.1 million to fill the adult shelter budget gap with general funds that would go to the base budget, and $438,909 to fill the outreach budget gap with general funds. I will note that there is a memo that was transmitted from Councilmember Stewart to the HHS Committee regarding the FY27 proposed budget for SEF. It is attached within the packet. And I'll just note for the committee and the public that there will be an April 30th joint work session with HHS and PHP to discuss the rental assistance programs that are provided across the county and individual departments. And so that conversation will include DHHS, DHCA, and HOC, and largely talking about how the funds are used within the Housing Initiative Fund. So with that, I will end this introduction and begin the presentation from SEF.
Thank you, and my apologies. I always forget to introduce myself. I'm Christine Hong, Chief of Services to End and Prevent Homelessness, and we'll start with our presentation. It does have a lot of data, I'll just say, and because of limited time, we'll move through much of the data quickly, and we'll highlight the key slides that we'd like you to see. So next slide. This is just the structure of SEF, and you can see many of the people that your offices work with on a regular basis, whether it be to connect someone who's unsheltered to outreach, or to shelter, or to work with folks who are in need, who are facing eviction and are in a place where we can prevent it, and to connect them to our housing stabilization services. So this is our team. I'm going to move fairly quickly through many of the slides, but if you have questions, please feel free to ask afterwards. And I know that Ms. Clemens Johnson will also provide the slides to you afterwards. Next slide. And of course, we cannot community partners. Many of them are here today. So much of the work we do, nearly all of the homeless services work, most of the housing work, much of the healthcare for the homeless work is done by our community partners. So I have to stop and acknowledge them, because we are so fortunate as a county to have so many incredible partners who are very experienced in what they do. Many of our partners have 30 to 50 years of experience. So wanted to acknowledge them here, because we can't do the work of ending homelessness without them. Next slide. We also have critical partnerships across systems, and we have a few systems here present with us today, but I want you to know that in each of the areas that SEF works, we continuously collaborate with our partners across many systems noted here. Next slide. So I usually do an overview of eviction trends. You've seen this before, and you can see from FY23 to FY25, there was a significant increase not only in the number of eviction writs that were issued, but also the number of evictions executed. But then you'll note in FY26 a reduction. And let's go to the next slide for me to go to talk about that a little more. So this is data from the District Court of Maryland comparing the number of evictions in Montgomery County to the other 4 most populous counties in our jurisdiction. And you can see Montgomery County, though it's second to the bottom, we had 207 evictions per month in the calendar year. So this is a different set of data from what I just showed, which was fiscal year. Let's move to the next slide, because this is an important policy change that came as a result of this council. So as a result of expedited bill 3125, it does appear that the number of evictions executed is going down. And I want to thank Councilmember Mink for her sponsorship and leadership of that bill, as well as the full council for your support. Evictions are really problematic in that when a household doesn't know when it's coming and doesn't have the time to avoid it, it leaves them in a state of crisis and definitely an experience of trauma. So the fact that we are able to, through policy, initially it's looking really amazing, less than 50 per month, in the first 2 months of this calendar year. That's really incredible. And it's how policy can come together with resources and services to truly reduce the experience of homelessness. So wanted to share that. I'm very proud of the fact that Montgomery County is now at the bottom with the lowest number of evictions thus far. And we'll continue to watch this data for the year, but definitely wanted to share this with you. And that, again, is a 55% reduction from the same time last year. Yes, thank you, Dr. Bridgers. Want to acknowledge the Sheriff's Office for all the collaboration they have done with SEF and our housing stabilization team and our many community partners that are working so hard to prevent as many evictions as they can. That collaboration, I would say, is unique because they work with us on timing, and they also, when there's a vulnerable resident, if they are able to, they will pause and on that eviction to see if we can come in with services and again prevent the eviction, because that is very, very hard for us as multiple systems to work through when the individual is an individual who's frail and elderly or someone with significant disabilities. So I want to acknowledge them as well. And let's keep moving to thank you. Sorry. Okay, so this is very, very exciting data to share because so much work has been done to move away from the trend of increasing homelessness. Here you're seeing our point-in-time count that we conducted on February 4th this year, and we counted 1,117 people. That is a 26% reduction from the previous year. And this is largely in part due to the investment in the SHARP program. So the largest reductions are with families. So let's go to the next slide so I can show that. So here you can see the total counted and the reduction there from 1510 to 1117 this year, between last year and this year. And then you'll see there was a reduction for individuals. It was a 9% reduction, 7% reduction for individuals. So overall, our system is making great efforts. But then when you move to people and families, you see a reduction from 712 to 375. That is a 47% reduction in people and families, most of whom are children. And to get to that, I'll just say, we didn't just reduce by that number. We had to continuously house families who are presenting. We housed 3 times as many families as you see in that reduction. So I just want to say that the work that the SHARP team, as well as our homeless services team for families and all of our family partners did to accomplish this is really incredible. And it's a sign that our system is working well together. And so just wanted to pause to acknowledge them and to say that the investment you have made, the investments our county has made have been meaningful and are making a difference in the lives of people who are at risk of and are experiencing homelessness. And then you can see also, I'm going to decrease. However, we also know that the weather conditions contributed to this significantly. It was sub-freezing temperatures leading up 3 to 4 weeks leading up to the point in time count and on the night of the count. And our wonderful outreach partners were working diligently to urge them to go indoors to shelter or to anyone they could stay with. So we believe what we saw that night was more a reflection of the weather. And I'll also say that we're doing incredible work housing individuals who are unsheltered. We have funding from HUD through the Special Unsheltered Notice of Funding Opportunity that we've used to house folks through the Street to Home program. People need to be unsheltered or have a history of being unsheltered to be eligible for that program. So we are making really great efforts. We also have a new outreach coordinator funded through HUD. And are working on our consistency in our outreach procedures. So there is really excellent work being done to decrease our unsheltered number. I just wanted to note that though you see a significant drop, much of that was weather related. Then we have also decreases in youth experiencing homelessness and veterans. The one subpopulation that has an increase is those who are chronically homeless. There was a 14% increase in chronically homeless individuals. Those are people who have an experience of homelessness of 12 months or longer, or who have had 4 incidents of homelessness in the last 3 years, with the amount of time being 12 months or more. And so a key point I wanted to make here with the increasing chronic numbers is that we know that the length of stay in our emergency shelters for individuals is lengthy. I'll say that. And we believe that people were timing into chronic status, which underscores the need for more housing interventions for individuals. And I'll talk more about that when we get to our inflow and outflow data, but wanted to flag that for you here. That was the only subpopulation that had an increase this year. Moving on, let's go to the next slide. These are some of the persistent and emerging drivers of homelessness in our county. Of course, at the top, affordability of housing. We've done great work there in Montgomery County, and housing is still not affordable to many people in our county. And all the items listed below are very important. We'll dive more into some of the federal policy changes in further down in the presentation, but let's move to the next slide. Okay, so this is where I'm going to move really quickly, just because we have limited time. We prepared a lot of data. We are excited for our team to share it, but we're just going to move through it quickly. So housing stabilization service, let's go to the next slide. This is the, you can see the increasing number of people who have needed eviction prevention and relocation services, and 2026 is on par to keep up with 2025 because we continue to see people, and this is one of our most important interventions. And I should state that all the data I'm about to present for FY 2026 is to date. So it's not a complete fiscal year since we're only in April now. But let's move to the next slide. So we'll go to homeless services. This is a map of our county, of course, with the street outreach partners who are assigned to the different areas. So in the Up County, we have Everymind, who covers all of the blue area. It's a huge geographic area. And then the city of Gaithersburg that covers the area in green. And then in the Down County area, we have Pathways to Housing, as well as Bethesda Cares. And Pathways also focuses on youth outreach for the entire county, but you can see that the amount of area covered in the Down County is smaller. And the reason why the assignments were made that way is because we do have a higher concentration of unsheltered homelessness in the Down County. However, we are seeing more people, and Councilmember Lutke, you've done such a wonderful job raising awareness on the increasing number of unsheltered individuals that we're seeing in the up-county areas, particularly in Olney and Germantown, even Poolesville. So this is why our street outreach funding is critically important, because each of those teams has 3 to 4 full-time equivalents. It's not a lot of people to do outreach over 500 square miles. And so we need that, because that is the way we ensure people who are outside continuously are offered services, which include shelter, but also housing. So, and if we don't permanently end their experience of homelessness, and I know there's often pressure to move or clear an encampment, they will just move to another location. It is not solving the issue. Let's move to the next slide. These are our street outreach numbers. So this is what contradicts what we saw in the point in time count. We continue to see a significant need for our street outreach services. You can see even year to date at FY26, that number is larger than the previous year. And we'll keep moving. This is our data for emergency shelters for families. The orange is our motel overflow, and the blue is for our permanent shelters. And you can see where the need rose across FY23 to 25. And we do anticipate that 2026 number to hold and be lower, possibly. Although one of the things that we've noted in our data analysis is that though we're using fewer rooms in the motels, we're also housing families much more quickly, which is good. But that means we can serve more families. So the numbers may rise above what we saw in 2025, but we are using significantly fewer rooms, as you saw in your packets. We can go to the next slide. We're so proud of our Healthcare for the Homeless team and our partners. The populations we serve are so vulnerable, and the fact that Montgomery County prioritizes healthcare, not just housing as healthcare, but actual services to be placed in our shelters is phenomenal. So we have primary care, psychiatric services, ongoing coordinations with hospitals, which is exhaustive work. I can tell you Felicia Davenport, who is behind me, she's on the phone all day, every day, coordinating with our hospitals. And that's really important to make sure that the transitions from a hospital back to our system are effective, and when the individual is ready to return. We also have a wonderful medical respite team and mobile dentist services as well. Keep moving. And I forgot to note that the demand for the services continues to rise, indicating the continual need for those services. And you see that here as well, particularly for psychiatric services. You can see that increasing over the 4 fiscal years, and already in FY26 we've served double what we served in FY25. So really much needed services. Let's keep moving. And so we'll start with the SHARP program in supportive housing. So this is a cumulative count of the folks we've housed from the start of the program, which was from that special appropriation that the council unanimously supported. And we started housing people in February of 25 using the SHARP program. It's all been families, but you can see how quickly we've been able to house a large number of families, 299. And that's as of March, and that accounts for nearly 1,000 people, again, most of whom are children. So it's really been such a success, and many thanks, so much gratitude for the council for overwhelmingly supporting the funding for the program. Let's keep moving. So this data is really important to note, because our so-called inflow and outflow data, that's inflow into the experience of homelessness and outflow into housing, permanent housing. This is how we track progress on our work of ending homelessness. And here you can see, this is for families, where the gray numbers, which are for when we house families, those are almost all larger than the number of families that are entering month to month. And that red line is the net change. And so that red line for most of the year has been below zero, and that indicates a decrease in family homelessness. really important. And again, the SHARP program really helped us to get there. So let's move to a different picture for individuals. So this is where you can see that the number of individuals entering homelessness, which it always goes up during winter time, that the number of those housed is far less. And that is as a result of not having enough housing placements for individuals. And then the net change in red is always above zero here across the past year. So this is a clear indication that we need to invest more into housing for individuals. And because of the success of SHARP, and I can tell you the past several months since we received that really important special appropriation during the shutdown, we increased the number of families we housed, and we actually weren't getting as many referrals as we had slots available. And so we were able to work in a preventive way with families using that additional funding, but we could also use it for individuals. And this is with staying below. So we had noted in the packet for FY27, our goal is to stay below using 75 motel rooms for families. We've been staying below that number for about 2 months now. We're at about 60 right now. Last week we were at 51 families. And so we think that will be possible in FY27, especially with additional funding as recommended by the county executive. So this is just a stark contrast to the accomplishments we have with families, and shows where we really have to do more work with individuals. Let's keep going. Rapid rehousing. This is noteworthy because our existing rapid rehousing funds do not go as far because rent keeps going up, and we do pay up to 2 months of rent for people in the rapid rehousing program. So just important to note. And then moving on to the next program, permanent supportive housing. Similarly, the numbers have gone down a bit, but not as precipitously as for rapid rehousing. Really important housing intervention for people who are vulnerable and who have disabilities. And we're going to talk a bit in a few minutes about impacts to our federally funded permanent supportive housing and rapid rehousing. But for now, this is our data for the last 4 fiscal years. We'll go to the next slide. This is formerly our rental assistance program, because that's also the name of the HIF funding. We changed it to the rental monthly assistance program. I think it's actually allowance program. And so this is also a very important preventive program in ensuring that those who are 55 years or older or who have disabilities have a shallow subsidy, because so many of them are on fixed incomes, and this helps them to stay stable in their housing. And it continues to be a very important program. Let's go to the next one. Office of Home Energy Program. So we did see a significant increase in the number served with a state change to categorical eligibility for OHEP assistance. This is utility assistance. We continue to see the same demand. In fact, with energy prices increasing, we are seeing more people coming to us this year. So this also remains a very important program. Go to the next slide. Okay, so this is where we're going to talk a bit more about some of the impacts from our federal funding and the risk of cuts. I'm going to pass this to my wonderful colleague, Dr. Diana Pina, and she's going to.
Good morning. So Diana Pina, Deputy Chief with SEF, and I'm going to provide an update on the HUD's Continuum of Care Notice of Funding Opportunity and how we're progressing to that. So earlier this year, through the Appropriations Act, Congress required HUD to renew the Q1 grants non-competitively. If they missed that deadline of April 1st, they would have to renew Q2 immediately as well. And they would also have to publish a NOFO by June 1st, 2026. As of today, both the Q1 and the quarter grant agreements have not been released by HUD. And actually, as late as last night, the National Alliance to End Homelessness posted a notice on the pending trial against HUD, asking the courts to please ask HUD to release the grant agreements due to the harm it's causing in communities. So we have kind of two problems that we're trying to address right now, and the upcoming COC NOFO, which we expect will provide guidance to significantly change the structure of our programs. The first change is a reduction in funding for permanent supportive housing and rapid rehousing. It's going to cap our community funding to 60%, meaning that 60% of Tier 1 will be funded, and we'll likely have PSH and rapid rehousing in Tier 1. But the programs that land in Tier 2, 40%, will likely not be funded. And what that looks like for us in Montgomery County is 5 to 9 programs out of the 12 that are funded will likely not be funded. We'll lose housing. This will be obviously a significant impact in our community, as Christine just explained, our capacity and how we're already trying to address our demand, and an increase in homelessness due to these cuts would really make it even more challenging for us to make sure that our folks are ending homelessness and making homelessness very brief and one time only. The other uncertainty is that we are unsure if HUD intends to renew the Q3 and Q4 grants, or if the new NOFO will replace those grants. And if that happens, then likely those programs will not be funded. You can, next slide, please. I just wanted to provide an image of our partners who are HUD grantees and receive funding from HUD. We have 12 programs, about $11 million. In the annual start date, that is equivalent to the calendar year quarters, and so you can see the progression of which grants will be expiring. We already have one that expired in December, another expiring at the end of this month, and another at the end of May. And in Q2, we'll have 7 programs expiring, and they have not received their grant agreements yet. And then we have 3 that expire in Q4, none in Q3. I also wanted to take a moment to go over our financial realignment of CEF. This was really done because we noticed within our financial structure that a lot of our contracts were not assigned to the proper division within CEF. So although this is a financial restructuring, it will allow our administrators and program managers to manage their programs much better, to be able to project expenses, assess gaps, track demands, and track their expenditures in coordination with that. Prior to this realignment, it was really challenging for us to get a true understanding of how much money was spent in diversion for families versus diversions for adult-onlys, for example. And now those administrators will be able to manage that in a much more clear way. So we believe this will improve our service delivery to clients because we'll have a true understanding of the true cost of our programs. So moving on to the budget impact on our adult-only homeless shelter services. This is really our core network of emergency shelters serving adult-only households in Montgomery County. If the structural gap is not filled, then we will have to reduce our shelter contracts by 9%. And this will result in a loss of 48 shelter beds. While 48 may not sound like a very large number, if you think about the day-to-day need and the data that we just saw, this will impact numerous households per year because we have to think about it in terms of bed nights. So this would lead to an increased experience in unsheltered homelessness, which would create additional burden in our outreach teams. This additional burden goes beyond our outreach team. It would also impact our crisis center, our libraries, our recreation centers, and other spaces that clients use, like buses, restaurants, as overnight shelter. It would also increase the use of hospital emergency rooms, which our clients sometimes seek to be able to stay warm during the night. And, oh, sorry, if you could go back to the previous slide. I wanted to make sure I've highlighted there the agencies that support our emergency shelter work. And as mentioned before, this is a crisis response, but it's one that is needed in our system, even if it's short term before we move folks into housing, because it sometimes really is a life-saving measure, especially during our overflow season where we're sheltering folks from the extreme weather. We can move on to the next slide. Same, the impact on outreach is similar. This is also a request to fill a structural gap in our budget. If this gap is not filled, there would be a 22% reduction to our outreach contracts. This would likely lead to a decrease in staff capacity. This would have incredible impact in our system. If you remember that map that Christine just showed a few minutes ago, Montgomery County is large, and we already have understaffed outreach teams trying to canvass the whole geographical area. If we lose even just one outreach worker, this will impact how often teams can canvass all of Montgomery County, the hours they can go out for outreach, the frequency they can go out. It would reduce our capacity to respond to community requests, which we receive sometimes 5 a week or more. And we try to respond to them in a timely manner, and a reduction in staff capacity would really limit our ability to do that and to coordinate with our partners. We work closely with the police department, Department of Transportation, with our multiple support services in the county, behavioral health, vocational support, the shelters, to make sure that folks are moving from unsheltered homelessness to shelter and, if available, to housing, which is ideal. I want to also highlight that Shepherd's Table is part of this budget line. Although they're not a street outreach program, they do provide in-reach services with their meal program at Progress Place. They're serving a lot of the same clients that Outreach and Shelter are serving, and they provide a space for engagement and it increases stability so we can work towards our goal of housing. They would also be impacted by this cut.
Before we move on to the next slide, I wanted to invite up Monica Martin, as well as Patrick Fromm with the Department of Libraries and Shauna Kress with the Department of Recreation. They have had significant impacts as a result of the unhoused population. Just wanted to share the impact if outreach and shelter services were reduced.
Thank you. I know that we have quite a few items, and thank you, Director Hong, for the presentation. Just looking at the multi-program adjustments, I think it's time for us to get into the line items and the questions associated with it. So I'm glad you've brought your partners to start discussing the items. And I want to thank you again for the presentation. You know, our county has experienced, decreases in, wages, which have not kept up with inflation. We're seeing increases in rent prices, and then the despicable actions by the federal administration, cutting federal jobs and accelerating inflation due to misguided policies have really thrown our system in flux. And it's basically gutted our social safety net services, and public housing programs are, as we just heard, are still in flux and impacted. And now it's going to be shouldered by the local government, which is already experiencing significant budget shortfalls to fill in the gaps. For those who have not participated in the point in time count, I was glad to participate. It's been a while. I did that during the city of Gaithersburg, but it's really just a snapshot in time of the work that you and your team see every day, the street outreach network as well. And so I want to thank you all for the work you do to especially get those emergency services to house our residents. And not only did we count the unhoused, but we also were able to connect most of them to resources and learn more about their needs at that time. So I did have a few questions, or did you have anything else?
Won't go into detail as Steph provided a lot of the updates.
Yes.
Just if we looked at page 2, just want to note that there are 13 vacancies within the department. 11 are supported by the general fund, and 2 of the positions are grant funded. The positions and their titles are listed here if there are any questions. Seth briefly talked about their reorganization, and we know that DHHS as a department has undergone a realignment. So there's details in the packets about the transition, and I want to note that the realignment ensures that staff are organized under the appropriate administrator for each area to improve oversight, coordination, and accountability. Most important, I think, to note is that the realignment did not include any increase or decrease of funding amounts or staffs. The FTEs remain the same. So budgetarily, it just realigned things. I will note that there have been some questions about the coordinated entry program area being eliminated. And as we saw from the PowerPoint, that most of those services were moved under administration. It is my understanding that the coordinated entry included the 7.9 FTEs, which consisted of that intake staff that actually answers that main line when someone is homeless or needs assistance, and they are the main intake staff. And then there was also staff that was to that is that those are really the staff that manage HMIS, the Housing Management Information System, the electronic system that by Ms. Hong is able to provide us that detailed information. And so we talked about Vantage during the administration and support services, and that's really the department's efforts for the systems and operational transformation, so like data analytics and those staff who really work in those programs and electronic systems, so that that HMIS team has that expertise. I don't know if Ms. Hong wants to further provide any context for that.
Yeah, all of the data provided to you today was provided by the Vantage team through our homeless management information system, as well as our EICM, centralized case management system in HHS. And last year they moved from within CEF to part of the Vantage team. And this has really moved our data analysis forward and enhanced it greatly. Our data analyst assigned to CEF is behind me, Nakia Ghulamali. She's been working so hard for the last month to prepare not just the data in the presentation, but in the packets that was provided to you. And that change has really, really benefited CEF and ensured that we are getting to the data we need in the most efficient way. And we're making improvements. So we hope in future work sessions we'll continue to provide more and more data and dig deeper in. So that was really a critical change in the way that HHS and CEF were structured. Thank you.
Okay, and I won't highlight the programmatic updates as the team has already talked about, but I think the investment that the council has made in CEF over the years speaks for itself in terms of the $1 million additional funding the committee just approved, so around a $4.1 million investment above and beyond what was appropriated for FY26. And so if we move on to page number 9, that is the start of the budget changes that are recommended. I will yield back to the chair to see if there are any comments, and then we can get started.
Yes, before we get into the comments, just a few questions about the slide presentation, and thank you again. Starting with the service provider map, I don't know if we can put that back up, Tara. The outreach, yes. With Every Mind, and I see Every Mind is here, our nonprofit partners. I don't know if Montgomery Cares is here, but we thank them. All right, so regarding this map, how often, when was the last time? Because I noticed up county, it just looks uneven, and I don't know what the breakdown is for each of our providers that they're getting to cover these service areas.
My apologies. So we looked at it. I presented that information when I met with Council Member Lutke, as well as the Up County Citizens Advisory Board and Council Member Balcom. And there is still individuals as counted during the point in time count in that down county area, but not by a lot. So it is something we're continuously evaluating. The challenge is the way the map is distributed, all of our partners are overwhelmed. And Diana was she mentioned we get 5 outreach requests a week. That's the chief's office. Our partners get outreach requests multiple, throughout the week and every day. And so it's something that we need to do, but we can't really change it significantly with the way the dollar amounts are now, the funding is now. And if we have a reduction, then it would further impair our ability to provide outreach in general. But we do look at it in terms of the number we served in the pit, and we just, the way our partners and our work is structured, it would be hard to change it with the existing resources. And I'm going to turn to Diana to see if she wanted to add anything further. Okay.
Diana?
No
Oh,
further
okay.
comments, thank you.
Go ahead.
Thank you, Madam Chair. I thank you again. I know we've been working on this issue closely on behalf of the entire up-county region. And one of the challenges that, aside from the sheer geographic spread of the area, which is, a lot of these places are not connected well to transit. They're not walkable. So you're really having to drive place to place to place to find the folks and where they are staying. And, in certain cases, we've had where either police on patrol have developed relationships where they know the people, so they're able to help tell us, hey, so-and-so is here today. Time to have the outreach worker come, right? So that we can make sure they're actually there in the place when the outreach worker arrives. One of the challenges, though, that we have experienced in the up-county region is consistency of the individuals who are going out. So that has been something that's really challenging, and knowing, they are not, that this is a contracted service and people come and go from jobs and things like that. But my ask and my knowing we have the geographic challenge and we have resource challenges, but is like, how do we manage better the resources we do have so that we are making sure that all the notes are in the system and that every point in touch is documented so that, should there be a change in personnel, nothing's lost. Because to your point, and you said, like, it's about consistently offering shelter, housing services, right? And it may take many, many times before the person will feel comfortable enough to say yes. But what they don't like is having to repeat themselves too. That's not helpful to them. And I noted that talked about the different the homelessness, and it didn't mention mental illness or coexisting substance use disorder, which those are significant factors that make the cases more complex when that is also there and needs to be addressed and needs to be supported. So and I hear you on the ER wait times, as I spent last night many hours in the ER with one of my kids. So it took 5 hours, and we were referred over there from urgent care. So it wasn't like we just walked in. We were, the file was transmitted, and you still have to sit there for 5 hours waiting to be seen, which is a lot. So everything that we can do to help tighten up those communications and those different pieces will be to the benefit of those who are experiencing these crises. So thank you.
Thank you, Councilmember Lutke. If you can, where we're talking about these contract amounts included specific, did you, but because I'm looking at the numbers, I just don't know how many people are being served across these different program areas, and there's a significant gap between what that map shows and how these programs are being funded. So if you could just share a bit more insight about this, it would be very, very helpful.
Yeah, we can provide that after the session. We don't have that
Yes.
readily available. We can
Okay.
provide that. Thank you.
Do you want to provide any insight about these numbers and the map? I'm seeing 800,000 for Bethesda Cares, and then the rest of the county, Every Mind, 146. The city of Gaithersburg, and why we're funding services in the city of Gaithersburg and why they're not funding those services. Anybody?
Is that in the packet?
It's on page 15
15,
of the
thank you.
packet. FY '27 contract total without the inflationary adjustment. Are those numbers incorrect, or?
We believe that there are some components missing, like to the Everymind contract, and then I don't think they're all the same. For example, you can see that the city of Gaithersburg amount is drastically less than others, and the city of Gaithersburg does also fund part of the outreach work, and then the county comes in and funds part of it as well.
I know, but I'd like to know why. As you know, we've already discussed tax duplication with our municipal levels of government. Why are we doing anything there?
For the city of
For the city of
Gaithersburg?
Gaithersburg, yes.
So it is also a much smaller geographic area. It is specifically the city of Gaithersburg. Now they will, and this is really excellent, go in areas surrounding, but it is comparatively less geographical area.
I mean, I appreciate this chart, but I need more information.
Sure.
And it would have been helpful to have this as we are making a decision. Before we get to full council, I need information on each of these contracts, who they're serving and the geographical areas. Because right now I see duplication of services and it's not consistent with the areas that they're covering. And so before all 11 council members vote, I want to be confident in how I'm explaining these programs.
And would you, I'm sorry, clarify where you see the duplication, just so I
The city of
understand?
Gaithersburg has their own department that oversees social services. So I'm just wondering why we're spending money in the city of Gaithersburg to do outreach.
Right, so my understanding is that this funding increases and supports the position, like for the manager of the outreach team, and then as I said, though they focus primarily on the city of Gaithersburg, there are some areas surrounding that, because they know the folks that they'll do outreach to as well.
Well, I just think it would be helpful to have more information.
Sure,
We're not
sure, we
going
will
to-
provide that, and I think Dr. Bridges would like to remark as well.
Thank you, Councilmember Sells. We'll work with council staff and our contract team to provide you with any information as
Yeah,
if
the
there are
numbers
any
from the
amounts.
previous
Yes.
years and what these numbers are funding. Because there is an inflationary adjustment to each of these programs. Okay, all right. And do you have any? All right, Councilmember Friedson?
Yeah, well, first of all, I appreciate that. That follow-up would be helpful. I think it really speaks to what the chair was just talking about, and also what Councilmember Lukey was talking about, of really doing a deep dive into understanding the dollars that we're spending. And I think these sessions have turned a little bit into like an overview of what we do, and not how we're spending our dollars and how we're allocating resources and what are So I think we got to move the strategy part to outside the budget session and season, which I think we wait until now to talk about this. So I think we got to fix that. And then we're not talking enough about the dollars and cents in the budget session. So I just, for future, for all of us, I think that would be helpful for us to kind of move in that direction. Point in time count. This is the first year I missed the point in time count, although I hope it was an excused absence. I had a 12-day-old new baby girl, so I wasn't provided an excused absence from my home to be able to do that. But I was up, so I was there in spirit. Ms. Hong and I have done it together a few years back, and I've been part of that effort. And it's just a window for us in positions of appointment or elected positions to have a small taste of what our partners are doing every single night, all year long. And it really is, I think important for us to, walk a night in your shoes. But, for us, it's agonizing work that we talk about all year. For you, it's just a night of work. And I just want to express our appreciation. We're scrutinizing and we're talking about these issues, but I hope it doesn't take away from the appreciation that we have for the folks in our community who are doing really, really challenging, really difficult, grueling work that's only getting harder, and you're only getting stretched thinner. And the $4.4 million to 350 people who are going to lose services and housing, the federal landscape here is just a gut punch, to say the least, not just to our community, but to those who are out on the street every night, dealing with these issues, who are not going to have the backup and the support that they have been used to, and we're going to have to grapple with that reality. I would like, we looked at the charts. I'm a little concerned in what we've seen that we're patting ourselves on the back a little bit here by the window of time that we're looking at, because the rate of homelessness was skyrocketing and we're seeing the numbers come down. But the question is, from where are they coming down? And I don't want to take a victory lap here. And so I think it'd be helpful for me if we could kind of redo the charts. It's not going to change my opinion, but I think it's just for intellectual honesty of where we are and what our community is experiencing. If we could do a broader timeline to look at the trend line over time. So it was year over year in certain circumstances and about 3 years in other circumstances, depending on which chart. Again, it's not a criticism, but I do think it would be helpful if we had a chart that looked at a set amount of time that you find to be reasonable. I would say at least pre-COVID, a decade seems reasonable to me, but some reasonable, justification for a time frame that allows us to look at the trend line over time. Because a year over year dynamic, if the baseline, I did a lot of data work in my past, and you can, pick a window and the window will tell you different things, but the broader you extend it, the more honest, intellectually honest, it is for us to really understand where we are in the context of, the total reality and not just the moment in time snapshot, which is not always a great indication. So if we could a formal presentation, but just to share with committee, ideally, and I think the whole council would be helpful. And maybe even we could include that, in the posting as an addendum, just so it's transparent to the public, so that they could see it too. If you go back to this setting, I think that would be, that would be helpful. So I appreciate that. I'll just, appreciate the dollars and cents. I do think that would be helpful for us, but I do just want to lift up this idea of, I really think we should do strategy work before the budget and then fiscal work during the budget, because I think we've set unrealistic expectations of the strategic changes that we're going to be able to make in the middle of a budget process. And I think it's unfair to the department, it's unfair to the partners and the advocates, and it's unrealistic for us to do that. And so I just want to, figure out a way that we can do that, in the off season, so to speak, and set up a process and a timeline if possible. Thank you.
I like that. Thank you so much, Councilmember Friedson. And just to clarify, increase from FY26 to this year's budget, does that include all of the supplements that were sent over by the county executive in FY26, or is this a 10% increase from FY26's base recommended and approved budget?
This is just the CE's recommended additions. It doesn't. He did not recommend annualizing any of the supplemental
okay,
appropriations.
okay,
So
okay.
the move, if you look at the top of page 2, the move from 61.9 million to 68.2 million reflects the 4 additions that are listed here.
Okay, all right.
I did want to comment, though, for the SHARP funding that because the special appropriation, the $1 million we received with that for SHARP, because that fell midway through the fiscal year, and that's when we were able to start implementing it, that it's a 12-month program, that those individuals, the funding for the remaining months of the SHARP program fall in FY27. So I do believe that is part of the consideration in the $2 million additional funding for SHARP.
Okay, 1 second. The reorg that is being recommended that we're going to be discussing shortly, you said that's not going to impact service coordination. It's just being reabsorbed under another. Okay, all right. Go ahead, Councilmember Friedson.
Thank you, Madam Chair. Question about that. I just want to find points. I was proud to work with Councilmember Stewart and Balcom to put together the emergency package and get the whole support of the entire council totally behind it. And the $1 million for SHARP was a key part of that. Food and SHARP were really the 2 critical components of that. And then support for our nonprofit partners was really the centerpiece of that. Could you just explain? I'm just trying to understand. I understand it's a 12-month, the whole kind of secret sauce to that program is that it's a 12-month intervention. And the idea is that 12-month allows for a transition that, moves out of the shelter and into permanent housing, right? That's the whole game. It's what I was talking about earlier. And I want to have a strategy where we're doing that as the rule and not the exception. And I think all of us are committed to that. That's our intention. I think, the strategy, the execution is where we need to improve and collectively figure out how do we work together to get there. When you say the consideration, does that mean 500,000 is embedded back here, or that we have $1 million encumbered, 500,000 of it won't be spent until FY27, but it's there, but not under consideration during the budget process because we already appropriated it and it's already encumbered? Because that would be my understanding, that there's 500,000 sitting in this program that's already encumbered, that was already approved by the supplemental appropriation as part of the emergency package. And that will allow for those folks who are part of that program to continue and get the full 12 months. And so it may show up somewhere that funding in FY27, but it's not under consideration by us today as part of the approval of this. I just want to make sure I'm understanding that.
Yes, a bit. I think if we start with budget item number 1 on page 9, I think what I was saying is it's not a dollar for dollar replacement of the supplemental. The supplemental was $1 million. This request is $2 million. And so if we look at the bottom of page 9, this the $2 million takes the total funding for FY27 to 8.9. So so this will support 396 households. Mm-hmm. So of the 396, 175 will be new, and then 221 families that are currently in the program will exist in FY27. So a portion of that 221 that we're supporting right now with the base funding of SHARP and with the $1 million appropriation will also be supported as part of this $2 million. So we would have to go back and see if there's a dollar for dollar, but this is adding the $2 million and recognizing that there are 221 families that will continue on as part of SHARP.
Right. So the idea is there's money that's already encumbered. This is adding to the money
that's already part of the base budget. And so that adding this $2 million will help sustain the 221 and then support 179 other families. Mm-hmm. So if we didn't approve the $2 million, this would just help sustain the 221 families that are currently in the program. So this 175 helps support the 2 million helps support 175. That is my understanding, but if somebody else wants to make some other clarifying point, that would be helpful.
Yeah, so it's important. I think that's Yeah, it's important to note that when the rent starts being paid, that's when the 12 months starts. And the way the program was designed in FY26, the ongoing funding is really necessary because nearly all of them, if they start on January 1 of a year, will have a tail. And so that continuous funding is needed. So what the $1 million introduced was our ability to serve more families. And they will continue to need the rental payments into FY27. We could use the existing funding that was there. However, that means we would serve fewer people in FY27. So the $2 million allows us to continue paying the rent for the families, the additional families we were able to serve in FY26, and serve the same number of people with the existing funding that was there, the $6.9 million before the special appropriation. And because it's $2 million, we can continue at the increased rate of housing families.
Got it. Okay. So what you were trying to say, it was a little confusing how it was framed. That's why it is what I understood. But basically, the $2 million essentially allows us to maintain the same number of people with the special appropriation, because the special appropriation was $1 million for 6 months. Now we have $2 million for a full year, and that will allow us to continue the folks who are already in it for the full 12 months, plus add back in the equivalent number of people. Those are new people, but the equivalent number of people.
Yeah. And I think we also have to consider the inflow and outflow. So at the beginning, when we hit July, people that were supported in FY26, as they transition out of the program, those are the new people that will continue as part of the program.
Right. So it becomes additive. So that's
yeah. So like what
if we don't do this, we would continue the people who have already received funding, but then we'll be back to the FY26 approved number of people.
Yeah, and the team has reported that no 12 months. So once they cycle off, they've been cycling off. They said there was 2 instances of families on, but it's truly been a 12-month. So everybody who's coming on is cycling off within a year period.
Right. So the $2 million does kind of annualize the special appropriation to a certain extent.
To a certain extent.
In terms of numbers.
To a certain extent.
Yeah, and I wanted to add, sorry. Just so not only if the $2 million doesn't allow us to continue funding the families that we house through the special appropriation, to cover the tail, it would eat into the $6.9 million of current annual funding that we have. And so actually our SHARP team has pointed this out to us clearly. We'd serve 27 with the $6.9 million that we received in FY26.
Because the rents are higher?
No, because the tail wasn't factored into the calculations of the $6.9 million. So then we'd have to absorb the tail of the special appropriation housed families into the 6.9.
The new fiscal year is paying for the tail plus the new people.
Yes.
And last time you didn't really include the tail, so to speak. Okay.
Yes.
All right. Thank you.
All right. Thank you to my colleagues for all of the questions. We will now get into this agenda item, and I'll turn things back over to
Report item 1.1.
objection.
Okay. Consensus of the committee on 1.1. 1.2 is additional funding for one-time funding of overflow emergency shelter support for families at a reduced level of motel usage due to funding added to SHARP. It's long, but it's just basically overflow emergency shelter support. 1.9 million, again, said that was one-time funding. The total amount requested for that the department has said is needed for FY27 is 2.7 million. The motel expenditures in FY25 were 4.7, and FY26 years to date was 2.8. If we add the 2.9 that the committee just approved, that would be a 5.7 million allocation for FY26. So much lower budget expected for FY27. I think the one question that has come up is why is it one-time funding? And DHHS has said that we want the opportunity to reassess the need for overflow motel sheltering based on the things that they have described during this work session. And so to ensure performance and cost control, they want to try to divert families from experiencing homelessness and therefore this is a one-time request.
All right, so without objection? Oh, go ahead.
Thank you. Just real quick, if I just wanted to add to 1.1 and just wanted to make sure that we make it clear for our colleagues at full council that as is to provide the same level of services, essentially, to be able to serve the same number of families. That so I just want to make sure that that's very clear to colleagues that we are looking to maintain same services that we had in FY26, and to not fund that would be a reduction in services. Thank you.
Did you have? I just didn't realize it was the same. I thought it was.
That's why. So if we look at page 9, where it says without the additional funds, according to the department, without the additional $2 million, the capacity to serve new households would be reduced by 68 households to 107. So
Yeah, it's the same thing that she just repeated with Councilmember Friedson.
Right.
So
So is that the same number of
175 new families will be entering the program, and that's what the $2 million is there to support.
They're new families, but
Yes.
we're looking to be able to serve the same number of families. Is that accurate, Director Hong? That we're
Yes.
right. So that's the same number of families being served. So maintaining the same level of services in the program. Thank you.
All right.
So the vote that needs to be considered is on item number 2, the 1.9.
Yes, without
Approval,
objection.
Consensus? Okay. And we will move on to item 1.3, request to fill the adult shelter budget gap with general funds. This is a request for $1.1 million. On page 12 of your packet, it lists the adult shelters that the clients of the program utilize. So this is just basically filling a budget deficit that will eliminate the need to reduce the FY27 contract budgets by 9%. My understanding from DHHS is that although they make requests for special appropriation, that funding is always needed above and beyond. And so they sometimes use quote unquote savings within the departments or slow utilizations of funds in other areas and divert those funds to staff. So this is really filling a gap. Without this funding, those contracts would have to be reduced for the next fiscal year.
Thank you. Just a quick question on this particular item. I know that concerns have been raised about the conditions at Neville Street, and residents have since formed an association. They shared a letter about the engagement and updates, and just wanted to know if you had anything to share about communication. Has anything improved, or?
Yes, thank you for that question. Definitely, our homeless services administrator and team have been working steadily with MCCH, the partner who runs the Neville Street Emergency Shelter, and has worked with their team to improve their case management, as well as the other concerns were raised. And the contract monitor, she performed an evaluation, an additional evaluation, which she does it annually, but this was after providing found that there was significant improvement in the case management as indicated in the records at the end of March, and we were really pleased with that progress. I also want to add that operating a very large shelter is inherently challenging. It's a lot of people, many of whom are very vulnerable, and so it's important that they have all the staffing that they need and the support and guidance from the county, but we are seeing improvement. So we that things will continue to improve.
Okay.
And council staff, I'll just add that in reference to the letter that you mentioned, I believe there was some misunderstanding, especially because our budget book isn't that clear, about the coordinate entry services going away. And so that's why during this meeting, we wanted to reemphasize there was not a loss of funding or staff, that things were just reorganized. Okay. And I think Christine talked earlier about those efficiencies. So there can be further, as Councilmember Friedson talked about further programmatic questions at a later date.
Definitely. All right. Without objection.
And for the last item, 1.4, there is a request to fill the outreach budget gap with general funds. This is a request of $438,909. The committee just talked about this item, but I'll note that the FY26 operating budget was 1.5. I apologize that we didn't have the line item detail that has been included for FY26, so I will ensure that that information is transmitted to the committee, and we can include it in the full packet to make sure that it is clear for the full
detail.
council to understand where the puts and takes were.
Thank you. Thank you.
You all have talked about this in detail, so at this point, it would be whether you would like to take a vote on if you would want to concur with the county executive's recommendation, or you could push this vote to full council if you would like to.
Let's say you. Strong opinions. Council member, you want to wait or just discuss in more detail and approve now?
I know there is conversation happening,
Yes.
excuse me, but I will just add that on page 16, the team did note that the proposed budget funding will not expand services similar to the previous program that we talked about. If the gap in the outreach budget is not filled, if the 438,000 is not added, the overall budget will be reduced by 22%. So this will impact the outreach team's ability to serve all areas of the county. And similar to what we talked about is that the department has used funding in other areas to add monies to those contracts when needed. So
All right.
I will,
So we will
stop
move
there.
approval of the item and just discuss in more detail when we have more information during the full council.
okay.
Thank you.
That concludes the items to consider for the CEF budget, but I will reference the
memo.
the memo on just one memo sent by Councilmember concurring with the executive's recommendation to support the 5.5 million in additional spending for CEF.
Oh, thank you to our colleague who couldn't be here.
Nothing else from me for this
Nothing
item.
else. All right. Well, thank you, Seth and team. And we will move on to our next and final agenda item, where we will be, Dr. Bridgers, you're staying, and you're going to be bringing some folks with getting settled. We had a briefing about this, about our culturally appropriate health program. So I look forward to more discussions post-budget about how we are serving and how they will be working under these new reorg parameters. I believe Tara will walk us through this very big packet, starting with the executive summary. Yes, we are still in session. We still have quite a few agenda items to go through. And I want to be respectful of everyone's time. So thank you, thank you, thank you. So it might be helpful to do a brief overview, Tar, and then we will go through each item during the deliberations after questions from colleagues. Just give everyone, anyone else joining you, Dr. Bridgers?
Councilmember Sells, no. Mr. Hodge is here in case there are any contractual questions as needed, but we will continue to go with the flow. I don't have any additional, I don't have any opening. In the interest of time, we're going to just keep moving.
We have quite a few dental related items. from lines 1.1 through 1.7 that we would discuss and potentially vote on them as a block. And then we will move on to the remaining line items. So, Tara, you want to get started and turn
Yes,
things
I
over
can.
to Dr. Bridgers?
Yes, I can get started if that is okay.
Yes, please. Thank
Oh,
you.
okay, we are beginning with agenda item number 3, discussing the FY27 operating budget for DHHS Public Health Services and the Minority Health Initiative / programs in the Department of Health and Human Services. I want to thank you to the team for being here and providing the information to help support the packet in information as the committee makes its decisions. So for public health services, there is an increase of $6.6 million or 5.6% above the FY26 approved amount for the service area. So, excuse me. FTEs are recommended to increase by 13.25 or 2%. So the executive recommendation includes $3.3 million in programmatic and staffing enhancements that are listed on page 1 of your packet. The vast majority of these requests are help to sustain services or are the replacement of grant funding, loss of grant federal and state funding. Moving on to page number 2, the executive's recommendation includes a $170,000 increase in public health services that is not required to be on the reconciliation list, and that is in reference to the tuberculosis grant reduction. That is a service that has to be required, that is required by the state. And so those are funds that we will need in order for the program to remain in compliance with the state's guidance. In addition to this, something that we discovered later after the fact was that tobacco enforcement should also be pretty much considered under the same category. There was a bill that passed in 2025 that put stronger language about local county, about how local departments need to increase enforcement. And so we cannot do that without dollars. And so that is now a state mandated function. So when we get to that section, we can of course discuss it, but it's not something that, based on the council president's guidance, would need to go on the reconciliation list. The executive's recommendation also includes a reduction of $45,000 in programmatic reductions. This is related to the hospice volunteer training services and professional training services no longer provided. When we get to those sections, we will talk through those items. Just want to note that the school health services budget items are included under public health, but they will be discussed at the joint EC HHS meeting. So they aren't included in the calculations or listed here, but certainly part of the service area. So I will not go into the MHIPS part of the discussion because that is a bit separate from what's happening with public health services, but we will revisit that information when we get back to it. There are several amendments that have been, there are amendments and memos that have been sent by council members requesting additional funds for public health services. There is an amendment that was sent by the executive on April 21st for the Americans Diversity Group's free medical clinic. That was in FY26 one-time funding, and it was requested that that funding be added to the budget again for FY27. So there is information in the packet to support that. There was also 3 memos that were transmitted. One memo was transmitted yesterday, so it is not included in the packet, but we will talk about it verbally, and there is a copy of the memo for the council members. But within the packet, there is a memo regarding the Montgomery County Pride Center, a request for additional funding for the FY27 proposed contract. There is also a memo for proposed funding for the Muslim Community Clinic Oral Health Program, an increase in that we will talk about when we get to that. And then there is also a third memo that is a request to maintain the dollars for the going into fiscal year FY27. So that is a brief overview. And that ends my part.
Thank you, Tara. I'm going to turn things over to Dr. Bridgers and his team before we get into questions.
Absolutely. Thank you, HHS Chair Sales, also Dr. Boyce. Our Chief of Dentistry, that's my title. I'm sure she has another working title or many titles, has joined the discussion this morning as well. Dr. Ashford and Mr. Sean O'Donnell are going to walk through their PowerPoint presentation, and then we will respond to council questions.
All right. All right, good morning. In the interest of time, we are going to go very fast. All right.
Dr. Nina Ashford, I am the Chief of Public Health Services and have the privilege of leading this phenomenal team. I'm joined by many of our senior administrators behind me who really are the heart and soul of this work. Next slide. This is a brief overview of our service area. What I will say is that public health services isn't just a single program. It really is the county's front door, our safety net, and our early warning system. So when we invest here, we reduce downstream costs across hospitals and schools, and they grow. Next slide. Next slide. So I want to just highlight, this is staff packet, but I think this is actually a pretty illustrative picture of what is happening. So we have 21 total vacancies. Of those vacancies, 10 of them are actually unfunded. So they just sit on our books because either we don't have grant funding for them or county salaries have outpaced level funded grants. So when somebody leaves, we can't hire, which has a definite impact on the work of our staff. We have 11 and I should note that most of those unfunded positions have been vacant for over a year because we can't fill them. We don't have any money. We have 11 funded positions, 7 of which are in the dental program, and 6 of them we have been vacant for longer than a year because they are either, for example, the hygienists are waiting for the classification study, which should be done in May, and we still have some classification things we're working through with OHR on the dental positions. So in reality, we only have about 5 true vacancies that are in active recruitment. Next slide. Yes.
Thank you, Dr. Asher. Let me address one vacancy that's been brought to my attention, and I've shared it with you and Dr. Davis and Dr. Rogers. That's the vacancy for the mobile health clinic driver. And so we are actively recruiting for that position. Dr. Rogers will drive the mobile health center so that we can maintain its operations. I've been trained to serve as a backup, so there won't be any disruption in services, and we're going through interviews as we speak. There's one today, so we should have that vacancy hired within the next couple of weeks, we think. So thank you.
Where can I find out information about where the mobile van will be on a day-to-day basis if I'm a resident seeking services?
Sorry, our schedule is on the county website, so there's a full calendar. If you Google mobile health, DHHS mobile health clinic, you'll see all of our locations.
Thank you.
Okay, next slide. So Montgomery Cares and Care for Kids, just a few high-level updates. We have continued to see an increase in the number of encounters for Montgomery Cares, which is great. It means people are using the program. Next slide. I just want to highlight when we look at the quality and outcomes of the program, we actually had a network adequacy study that was done and showed that 87% of the primary care visits are able to be made within 30 days. 69% of specialty care visits are able to be made within 30 days. So this is standard within the normal benchmarks for Medicaid. So even though this is a safety net program, we are still providing a high quality of service. Next slide. I should also note this is a great value for the county. The annual cost of Montgomery Cares per patient per year is $515, which I don't think any of us could get a primary care visit for under $515, and that encompasses all of their services. Next slide. So Care for Kids, enrollment in both Care for Kids and primary care visits, I should note, has slightly declined compared to FY25. That is outgrowth of the current political environment and the uncertainty among our community. I will note that although behavioral health encounters have decreased, we have seen utilization for specialty services, specialty dental, and medication is actually higher and is projected to run slightly over budget, as you'll see reflected in the county executive's budget. I will also note last year we've council funded the reproductive health services. Both CCI and Mary Center have actually begun providing reproductive health services services. About 35% of the youth in Care for Kids will be covered by these two providers. And then once we work out kind of all of the implementation kinks, they're going to be rolled out to the entire program. Next slide. This just looks at the number of Care for Kids children that are enrolled. The blue line is FY25. The red line is FY26. It just reinforces the slightly declining enrollment. Next slide. And this looks at encounters, so the actual visits by the kiddos. Next slide. Enrollment summary. So overall enrollment's growing. It's driven primarily by renewals, but new enrollment is inconsistent. I should note that. We are seeing active enrollment slightly decline, but utilization is stable and actually increasing. So even though we might be seeing fewer kids enrolled, we are seeing higher utilization of all of the services. All right. Next up, we'll just briefly give an update on county dental services. So this is a huge win, and just want to reiterate thanks to the council and the county executive for all of your support for the dental program and the investments you have made in the dental program. One thing that I want to note is we've had lots of conversations about our wait times, and I am very happy to say that we have seen a 38% reduction in wait times for a dental hygienist visit, 76% reduction in wait times for general dentist, 20% reduction in wait times for oral surgeon, and 100% reduction in pediatric dentist wait times. Currently, no wait times. Patients are receiving immediate appointments. I need to give a huge shout out to Dr. Boyce and the phenomenal dental team, her leadership that has really been able to make this happen. Next slide. We did pilot, which was funded last year and is going really so we, as a reminder, there's an annual max of $700 per patient. Fees for basic services range from $0 to $8 per visit. And we'll just, for the sake of time, go to the next slide to talk about some of the metrics. So this data was as of February. We have a large number of pediatric patients due to referrals and the school-based campaigns, and all of the community schools. We have seen a total of 195 patients that have been appointed as of February. This just gives a breakdown of the zip codes and the gender, adult versus child, it's been a great partnership with our private practices, and actually I think a great model. We wanted to test it out to see if this public-private partnership model would work and allow us to help get waitlists down and see clients faster than what we might be able to do in the county dental, and I will say it is working. So we are very excited about that. Next slide, and I'm going to turn it over to my colleague, Sean O'Donnell.
Good morning. Sean O'Donnell, Deputy Chief for Public Health Services, and full disclosure, I came out of the Public Health Emergency Preparedness Program. So the reason that we've been asking for a position to be moved from the grant to the general fund is because the grant just can no longer handle these costs. Federal grants that come through the state to the locals for public health emergency preparedness. And then the third grant, which is an Urban Area Security Initiative grant that has historically been, over the last 5 years, $50 million to the region, was cut to $4.4 million in the past year. Public health historically gets about $100,000 to $200,000 of operating costs or personnel costs. We are scheduled to get $0 in the coming year. This has meant we lost, since the beginning of the pandemic, we've lost 2 contracted positions that were full-time supporting this team. As you're probably aware, public health emergencies disproportionately impact our communities of need, our minority communities. And so when we do those responses, it's very important we have skilled staff, experienced staff that understand the Montgomery County community and understand the equity that's necessary to bring appropriate responses. So we've just, in these slides, I won't go through all of this, but this identifies the processes. In a perfect world, you don't see all the things that the Public Health Emergency Preparedness team is doing, but they do work with all of our county partners. They are part of almost every one of those mass care incidents. When people lose housing, we provide public health support, and we are constantly working with things that pop up. And usually we hope we don't have to go public with exposures to certain diseases, but we work closely with the disease control team to make sure they have the resources they need. Next slide. And so that really is just an understanding. Likely within the next year, we would be forced to are reliant solely on federal grants. The public health grants last year, in fact, only came in at 70%. And then after about 4 months, they added the final 30%. So we are working in a risky environment with those fundings.
Thank you, Sean. Next up is HIV STI services. So just want to note for 2025, we served about 791 HIV clients, 3,200 appointments, the majority of which were Latino or African American. Next slide looks at STI services. About 2,700 clients, over 19,000 tests performed. Again, predominantly Latino, Black, African American, and again, just want to highlight the great work of that team and the partnerships with Montgomery College to specifically try and reach out to Black women. Next slide, maternal and child health home visiting program. So this is just a high level FY26 numbers to date. Remember, there are 2 programs, the Montgomery Perinatal Program, which has served about 1,400 patients through March of FY26. This is a 22% increase in patients from the same period last year due to the state law legislation around infant at-risk forms. They have revamped their client education classes as well. Babies Born Healthy, which serves African-American moms with Medicaid Down County, has seen 226 clients as of FY26. Next slide. I'm not going to go through this because we talked about this at the OLO session, but just looks at the outcomes between MPP, BBH, and SMILE for our programs. Told you guys I was going to go quick. Okay, retail tobacco enforcement, Sean?
Okay, this is one of those areas that the state has legally delegated the enforcement to Montgomery County. We have that responsibility. In fact, it's been expanded in 2024 with the Tobacco Retail Modernization Act. We currently do not have enough resources to fully do all those inspections. We have over 500 retail establishments. I believe it's 584 retail establishments. 84 of those are vape retailers. We're required to inspect every one of them annually and do coordinated testing to make sure they're not doing underage sales. We, in FY25, completed about 100 compliance checks out of those 500 plus. This past year, we're on pace. We're currently at about 147, so there's been improvement, and that's year to date, but we are still a significant ways off from being able to do all of these, and we just don't receive enough resources through the state grant program for this. Again, this is something that we're legally required to do, and we're asking to convert a 0.2 grant-funded position to a full FTE county-funded position to enable us to improve the amount that we've done. I'm sorry, that was 137 compliance checks in FY26. So we certainly want to get closer to that 586 sites. If a place is found to be out of compliance, we are required to do a follow-up check. So that would add even to those totals.
Next slide.
Okay. So within the TB program, Montgomery County has, we have a few slides here showing the number of infections that we are looking at and as well as the number of latent cases. Thank you. There we go. So we have, you can actually see from FY25 through to FY26, we have a reduced number of visits. That's not a reduced number of infections that are occurring. That is a reduced capacity to see all of the patients as frequently as we'd like. The grant funding that comes from the state has been reduced dramatically down to $25,000. We don't expect that to recover or go up. In fact, it may go down to nothing. This disproportionately affects Montgomery County that has approximately 1 in 3 TB cases in the state. And that reflects the fact that the vast majority of our TB cases are foreign-born, and Montgomery County has about 1 in 3 foreign-born populations in the state. It's essential that we keep up not only in the active TB cases, but also the latent investigations, which helps prevent those from becoming active TB and spreading. The team does a great job. What we don't have in our budget is the operational costs. The county maintains a radiology suite with a negative pressure room, which is important. Outpatient radiology does not typically have negative pressure rooms. So our clients, if we did not provide this, our clients would have to go to a hospital and incur those fees for it. The operational costs also cover the labs that are done with patients and some of the medical supplies. And so that's what has been put into the budget to ensure that we can keep providing these at no cost to the clients. Public health is not allowed to charge clients for TB services. That's part of the no charge list at the state level.
Next slide. All right, and last programmatic update, and then we Pride was funded last year. They opened their physical location in Bethesda. We have seen growth in participation of events, both large-scale events and the sustained core programming for MoCo Pride. They use a strong relationship-based model, and we are continuing to work with them to try and standardize their service metrics, particularly around testing, referrals, and outcomes. Clarity around, services to Montgomery residents. We get actually a lot, which is great. We get a lot of participation from folks outside of Montgomery County as well, but looking at, how do we really continue to focus on MoCo residents and helping them build that foundation and infrastructure. So with that, we can go to the packet.
Well, thank you, Dr. Ashford and Deputy and the entire public health team and HHS department for all of your work. I know we have some questions about some of the line items, and so I'll just start at the top. Or do you want to go through the items and we'll ask questions as we go through?
Yes, I'll just briefly breeze through the packet
Yes.
and then we can get to the budget items. I will
Yep.
go quickly. So item number 3 highlights the vacancies, but thank you, Public Health Services, for the update. Public Health Services was part of the reorganization of DHHS programs and services. The most significant change in population health, it really transitioned a lot of programs that have kind of been dumped, I will say, in admin. So the Healthy Montgomery, Health Promotion and Prevention, the Mobile Health Clinic, and were moved into community population health. And also there's a new program we haven't talked about much, the Community Reinvestment and Repair Fund. That committee has started to meet. They are provided funding from the state as a result of the change in the marijuana laws. And so they get direct funding, and they are meeting to propose grant programs to help programs adversely affected by marijuana. And so that program in particular moved to cancer and tobacco. So that reflects most of the changes, and I understand there are not to be any changes in the budgets or FTEs. Yes, just confirm. Public testimony, we heard a lot from the community in terms of the programs under public health services. Namely, our boards that are in public health are the Montgomery Cares Advisory Board and the Commission on Aging. We did include their testimony about their requests for enhancements. Those are generally related to the healthcare for the uninsured programs, and I will reference those as needed, and please feel free to bring those up. The program services areas are listed on page 4, 5, and 6 of your packet. And that concludes pretty much the overview before we get into the discussion items. And for the discussion items, the chart looks a little bit different because there were so many items I wanted to break it down. So there's areas of where what must go on to the reconciliation list as health services change is not required on the rec list. And as I noted, there's another one to consider, which would be tobacco enforcement. And then the last chart is for the MHIPs, which we will talk about separately after this discussion. And also, I would suggest that after we go over the public health services recommendations, that we talk about the memos sent related to the contracts within public health services. Okay. Should we proceed with the first item? Yes. Okay, great. The first item, I've broken this off into the section areas, so it may jump around a little bit, but if you have questions, please let me know. So the first item is Montgomery Cares. Just to provide a brief programmatic overview, is that there has been a lot of focus on the Access to Care work group, who is really looking at availability and coordination and equity of healthcare services across the healthcare for the uninsured programs. But there's always a large focus on Montgomery Cares because it serves 27 to 30,000 residents each year. That information is detailed in your packet, but the first budget item is the 1.5 million request for the Montgomery Cares primary care reimbursement rate increase to 52% of the cost of care, maintaining the same level of encounters that was funded last year, which was 78,000. So that is the executive's recommendation. On page 8 of your packet, there is the history of the past 10 years of the rate changes. So in FY17, it was $71. Up to FY26, and the current rate that they are receiving right now is $113.37. The recommended rate has, the recommended increase rate is $130.82, and this is an increase of, where did that? I thought I had included, an increase of $17.45 for the clinics. And so here you will see the breakdown and the last chart on page 8 of the total and how that is calculated. There is the primary care reimbursement rate, and then there's also the consideration of the indirect rate that because the money flows through PCC to the clinics. And so that so their rate would be $130 if the totality of the 1.5 is recommended by the committee. The council staff's recommendation was to concur with the county executive's recommendation. But if the committee would like to identify savings, my recommendation would be that there would be a reduction to the rate. Council staff can do those numbers after the fact and present it to full council. But, you know, we could make those as incremental or as big as you want to, depending on what type of savings the committee could potentially want to capture out of the 1.5 that's recommended.
I support the county executive's recommendation. I think we're all in agreement on that.
Okay. Consensus of the three? All right, great. Next item is the 1.2 for Montgomery Cares endodontic care and services. The executive is recommending $19,440 to support endodontic care for Montgomery Cares patients. Say that 5 times fast. This funding will be utilized for endodontic equipment and supplies utilized within the HHS dental clinics to provide molar endodontic root canals treatment within their practice scope. And it will also pay for private practice endodontists to provide advanced dental specialty dental care that is out of the scope of what happens at county dental services. So this is what I would say a relatively small amount of money, and this funding is new, but they're not considering this a pilot program. Funding has been used at other times to help support endodontic care, but this is the first focus of the county dental services to allocate specific funding to meet this need.
Without objection.
Okay. To Care for Kids, as part of the Healthcare for the Uninsured programs, DHHS, Public Health Services, just provided an overview of that program. So the item 1.3 on page 10, dental equipment and supplies to support Care for Kids clients, was $50,000. This amount would actually be added to county dental services, but
Without objection.
would include. Oh, okay.
I did have a quick question about that. This is the dental equipment and supplies, I believe, is the next item for the one we're talking about. How many students do we know will benefit from these dental services these are just for the community schools, correct?
Correct.
This is for the program in the schools, for the school-based program. Last year, we served 793 students. This year, it's slightly down because of the current political climate, but we still are just, I think, around 500 already for this year. What has happened also is that the number of community schools has just exploded compared to when we first started this program initially. When we were given funding, there were 26 community schools. Now there's over 77. We are in the process of trying to get a new agreement with MCPS so that any community school can be seen. They have also asked us to, obviously in that number, there's also special needs schools, which is a new thing for us. We can do it, but there's a huge need. We just got a call yesterday from one of them. So this is to support the expansion of services to all those community schools, those high poverty schools.
So do we know if these students, qualify for Medicaid?
We have a small
Medicaid?
percentage that do qualify for Medicaid.
Okay.
And we want to maintain that small amount, or I shouldn't say that, but keep that amount so that we can qualify for loan repayment for our staff, which can go down another rabbit hole. There's a huge, need for dental hygienists. We need to recruit them, but the overwhelming majority of these are for the healthcare for the uninsured, the Care for Kids students. I also want to add that with some of the recent issues that have come up with reductions in fluoride in the water, we just want to make sure, and that could be a temporary thing, but we want to make sure that we're doing the best to address this vulnerable pediatric population that, yes, overwhelmingly we're serving Care for Kids children, but even those Medicaid children need this preventative assistance too.
Okay. Thank you.
Okay, there was consensus on item 1.3 from the committee. Moving on to item 1.4, there is a 5% increase to the CFK specialty care dental services of $8,761. So this funding would actually be added to the Primary Care Coalition contract. So once children are seen at county dental, if they need services that go above and beyond specialty dental services that the county dental can't provide, the PCC staff and contract staff organize access to specialty care dental services through the budget. And would take this to 100. For the committee consideration, council staff recommended to concur at minimum with the executive's recommendation, but I did add some bullet points is that there really was no rationale of the 5%. There's a 5% to East County Dental too, so I was not able to get clarity on where that number came from or why that level of increase. From my knowledge of the program and what was provided to me is that the impact of 8,761, the program could only treat an additional saying like $500 per child who needs specialty dental care services. But if you think about specialty dental care, sometimes that requires like sedation of a child, which are provided in special environments. It's not something that you can get everywhere. And so I wanted to note that the McCAB recommended an increase of 71,708, noting they could serve 125 additional patients. So the delta between what is recommended by the executive and that suggested amount would be $62,000. So I just wanted to point that out for the committee's consideration, but to concur with the executive's recommendation at minimum.
I mean, it's such a small amount, and I mean, if our kids' dental hygiene is not up to par, it's hard to chew their food correctly and even concentrate in school. So I would move to add the increase. It's going to go on the rec list.
Yes.
But yeah, I feel good. You know,
Consensus of the three?
Yeah.
Okay. Moving on to item 1.5, we are running through all the dentistry items. Is there an hourly rate increase? $196,640.
Yeah, without objection.
Okay. I just want to make sure that's captured for the record.
Oh yeah, I'm looking at both of them.
Okay, thank you. Moving on to item 1.6, dental equipment replacement to remain in legal compliance with the state requirements. That's a request of $75,000. It is listed in your packet the type of equipment that we are talking about for panoramic radiography machines.
Without objection.
Okay. consensus of the three? Okay, I will note that. Item 1.7, starting on page 14, there's a 5% increase to the East County Dental Pilot. The Public Health Services provided an update during their presentation, and we will make sure that you all have a copy of that for your reference, and I believe it's also in the packet. And so there is information about the utilization over the year. The program, even though the funding started in FY26, it always takes a little while to get up and running and get contracts going. So they begin seeing patients in November, and the number of patients year to date is listed in your packet. Funding for the East County Dental Pilot in FY26 was $300,000. This 5% will take it to $315,000. I concurred with the executive's recommendation. I did not make the same recommendation as I did for Care for Kids, even though the 5% is still no rationale, is that there are a lot of dental resources for adults versus children. That was just my thought, but any recommendations of the committee can be considered.
Yeah, I think this is going to go on the rec list. It's such a minimal amount. Yeah, I think any increases should go to the kids, and but it'll go on the rec list, and we'll make that decision.
Okay. Noted consensus of the three members of the committee. We will, for that item 1.7, we will move to item 1.8, which is continue emergency preparedness response staff previously funded through grant funding. This is a 1 FTE for $185,000. So the Deputy Health Officer, Mr. O'Donnell, provided a bit of background about the reductions that have been happening within the Public Health Emergency Preparedness Grant. So this funding would actually support an existing position that they have paid, that has been supported by a grant since 2003. Mm-hmm. So it's a position that has existed for more than 20 years. An emergency management specialist for a grade 26. On page 15 and 16 of your packet, there's detail about the position and the work that it does. Council staff were recommended concurring with the executive's recommendation.
Yeah, I just, how big is our public health department right now? Is this just one position? This is just one position. Okay.
Yeah, within that team has currently 7.5 FTEs. Mm-hmm. At one point it was 9.5 FTEs, but as I mentioned, they've lost 2 positions over the last few years.
Okay. And so this one position was previously funded through a federal grant? Okay. And so what sort of projects is this person responsible for doing? What reporting requirements are associated with this role? Given that we're not in the middle of a pandemic, I'm just wondering across these, now there's 7 positions remaining? Okay, so what are they responsible for on a day-to-day basis?
So this person supports the overall mission space. The grant requirements are some of the most extensive set of requirements that I've experienced with grant reporting. There's about 15 different sets of documentation required each year. There's one of our slides showed the range of preparedness capacities that are necessary, ranging from having an ability to expand laboratory testing, which we did during COVID with contracts and with in-person PCR collections. There's a need to coordinate with community partners, which the team does with ABS as a warehouse capacity, with law enforcement, with fire EMS, to make with the hospitals, of course. And so we work with all of those groups because the hospitals are all private. Much of the work that does come through and funding that does come through from the state requires some sort of public health interaction to help coordinate their activities. During COVID, there was a limited number of respirators that came out from the state. And public health was vital in making sure that those respirators could be shared amongst the hospitals. They identified and stockpiled PPE that at the beginning of the pandemic, when there was no PPE, they distributed that out to the community, out to the hospitals to start with. Yeah. So there's a wide range of capacities. There is another piece that we'll get to in a little bit about a reduction in operating funds from that team. Mm-hmm. And by moving this position over to the general fund, that will create a little breathing room for that operational space, and that's why they targeted that reduction.
Yeah, I appreciate the context. I just don't know if that's necessarily a good use of funds right now, given that there's 7 FTEs already in this role. And we're just trying to be as, realistic as possible about where we have to, be able to streamline the services that we're providing. And so I do not support the county executive's recommendation, or we can put this on the, so.
Fine with it going to the rec list, or fine with it
Like cutting it.
cutting it? Because I'd prefer, given the quantity of things that we have already placed on the rec list that we have left up for consideration, to leave this on the rec list as well.
Yeah, that's fine then.
Reckless is fine with me.
Okay, we could put this on the rec list.
And I'll just note, this is a current position, so if the funding is not approved, then the position, the person would no longer have.
The program will be very close to not being able to fund it. June 30th, we would likely try to find a way, but that operating budget will be next to nothing.
Okay, just want to make sure that's clear for the record.
Yes, and then team members, grant writers.
Not as a specific skill set, but they do prepare the grant application every year with the state.
So what are they doing to explore new grant opportunities? Is anyone tasked with that?
Well, as I mentioned earlier, they had a number of proposals put into the Maryland Emergency Response System, totaling a request for $200,000.
Maryland. Are they exploring outside of the state, nationwide? There are a lot of global funding programs that can assist with public health response and potential emergency coordination.
Yeah, I would say in general, anytime there is a grant opportunity that makes sense and applies to any of the program areas, including FEP within PHS, we always put our foot forward, whether that is us as the health department or collaborating with community partners. And Kathleen Sheedy is a big support of helping us find those as well when they're available.
Okay. Yeah, I would love to hear more about, how we are compiling that list of grant opportunities, knowing the challenges and barriers for grant opportunities at the federal level. It would be helpful to see how creative we are becoming to explore outside of the federal government with some other nonprofit funding entities. Go ahead.
Yeah, so it's a grant funded position.
Yeah.
We heard in the last meeting, we talked about grant funded positions of how they're hired on a term basis because it's pending grant funding, which is drying up. So I just want to bring this full circle because the suggestion is if the funding doesn't happen, then we have to eliminate the position. But has this been treated since 2003 differently than the other grant funded positions that we talked about in the previous meeting, where we're hiring somebody on a annual basis or on the timeline that the grant funding is based on, contingent upon the grant funding continuing?
That is part of the hiring listing when positions are brought on. That they are notified that is contingent upon there being sufficient grant funds.
Okay, and so is it a contractual position or is it a merit position?
This is a merit position.
Oh, we have someone coming to add more context?
Jason Rendell, Chief Financial Officer, HHS. It's likely, as I don't have the specific position in front of me, but it's likely a term merit position. And so each of those positions, in June, we request an extension for them for another year. So if it was eliminated, it wouldn't get the term extension requested, and the position would end. We do, as was stated last time, make every effort to find the person a transfer to another position within HHS as possible. But if that is not possible, then the person would be out of their employment.
Can you remind me how many vacancies that we have? I know some are in progress for interview. They're all at different stages. Can you remind
Within
me?
public health services or across the
Across DHHS, as we talk about in the overview, was 159. And I believe there was also, there was a bit of extended conversation about the 13 positions that were on hold. Actually, as noted, 7 of those 13 were in public health services under the STI grant. So they were on hold because there was no funding. And so I could pull up the additional information on those other 5 that were on hold if needed.
But this is separate from those that are already funded, correct?
Yes, but if it's
Okay.
not funded, this would get added to the list of unfunded positions.
Okay.
So, hoping what I'm about to ask or say helps clarify why I said I wanted this to still be on the rec list, and to talk about sort of the time we are in, because I understand Councilmember Friedson's questions, which is like, hey, these are always term limited because they're grant funded, and that is in the emergency management space, that has been the way of life for decades, right? Whether it's OEMHS or management roles, because of the way they have been funded traditionally, come through FEMA and or other federal partners that come to the state that then come to local governments. We are operating in bizarro times where FEMA practically doesn't exist anymore. And the federal government has decided they want to push more of emergency management and the financial support thereof, along with homeland security functions outside of their utter fixation on immigration, right? We all are aware of that. But everything else that is important and valuable in the homeland security space, they've just like chucked out the door. And they're forcing states to handle that directly. So when we're talking about this, yes, we are talking about something that has traditionally always been grant funded. But because of these changes, the landscape we are living in, above and beyond cuts that the feds are making in other places, we will start losing any emergency management infrastructure that we presently have in place locally. And there is no federal net. There is no federal service in this regard. They're not coming when we have an emergency, when we have an outbreak. They have thrown up their hands and said they don't care. So that's why I felt it was important to put this on the rec list, because yes, we do need to pursue grants and things like that, but the way money is coming or not coming anymore, and the decision of the federal administration to say, these are just functions we don't want to have anymore, makes it so that we do have, as a local government, need to consider how we want to manage this moving forward, because we are in a completely altered structure. Thanks.
And I will just note to that point, thank you. One of the many reasons Montgomery County was so successful in COVID was because of our investment in our public health preparedness and emergency management. You know, the saying, stay ready so you don't have to get ready. This position helps us stay ready, because the time to hire is not when you're in the middle of a pandemic. These teams are constantly going through drills, whether it's for a weather event, a radiological event, a nuclear event. They just had a drill on Tuesday where they're sending out test messages. Shady Grove has, so I just want to note that I totally understand the budget environment, but I want you guys to understand what would not happen if, it wasn't funded.
I certainly understand. And if we were starting from scratch, I would unfilled positions, and I know my colleague's going to ask for more information. So we are making tough decisions and also looking ahead to ensure we're prepared for the future. And so,
Yeah, just as a quick follow-up, ready to vote on this, and I think rec list is a good compromise. I'm happy to move forward with that and understand the sensitivities here of how a lot of these positions have historically been funded. It would be helpful for us to get a full list, not just of the positions that are on hold currently, because you've done an analysis and determined that they may not be funded with federal grants that we have probably taken for granted, frankly, and unfortunately, a cruel environment has made that very difficult. But if you could just provide us a list of all of the grant-funded term positions in HHS, including the ones you do expect for us to have, and just how we're treating that. I just think that context is important, and I don't think we have historically distinguished in the budget process between them because we have taken them for granted. I think we're in a new environment, and we should distinguish. So I just think that context would be helpful. The number of positions, but also specifically what position, in what department, are they filled, are they vacant, are they on hold, because you're concerned about that. I think when we come back to full council, I think that context would be very important as we take up all of, not just public health, but all of the HHS budget, since the grant funded position and state and federal funding has been such a part of the way in which this department and various divisions within it have been funded over time. Thanks.
No problem. Thank you, Councilmember Friesen.
Do you want, so all positions across the department of the 2,000, there's like 2,100.
Yes.
So the just the separations of the ones that are general funded and the separate and
Grant
funded.
funded, term limited positions across DHHS.
Okay.
Thank you. Okay, next.
Is consensus to go on. All right, we will move to item 1.9 on page 16. This is the request for the nursing home inspection staff with an assumed start date of January 2027, 5 FTEs, nearly $400,000. The HHS committee has been briefed over the years about the nursing home inspections that for a long time there was an MOU in place prior to 2021 where the county maintained a long-standing MOU with the state, allowing a team of county surveyors to conduct the survey, the certifications, the surveys, and complete investigations on behalf of the state. The team consisted of 8 to 10 nurses, and that MOU terminated in 2021 and discontinued the services as July 1st. So the MOU is currently being finalized for DHHS to resume nursing home inspections. There has been a lot of discussion back and forth over the years. Page 17 highlights the 5 positions that there would be 4 FTEs that would be the community health nurses. It will take a while for them to go through the training, approximately 4 months. There's a CMS level, there's 2 CMS level trainings that they would have to go through, and there are minimum requirements of those surveyors in terms of their RN experience and maintaining their licensure in the state of Maryland. And there's also a nursing manager FTE that is part of the 5. So staff's recommendation is to concur with the county executive's recommendation. However, I wrote this back a few days ago, is that given the timing of the MLU, I believe the committee could consider not funding this item until we have the MOU. I'm not saying or suggesting that we use supplemental appropriations in the middle of the year, but this has really been a long process, and this would be allocating $400,000 in this tight budget time. So once we all had the MOU signed, I think my thought is that, you know, you could be proactive or reactive. And in this situation, we have been on hold for so long with the state.
Yeah.
We have been on hold. I did ask for an update on the MOU, but so I assume the onboarding and training process, if the MOU has been signed, but if the MOU has not been signed, then what do those people do in the interim? So I just wanted to put that out there as a consideration for the committee, but my initial recommendation was to concur with the executive's recommendation.
Dr. Bridgers, anything to add about the positions? Have we created the opportunities? Are they visible on OHR?
We can't create the pins until we have the budget approval to do it. So unless, I don't know, somebody gave us an exemption to create them before funding. I will just note, we have been going back and forth with OHCQ on this MOU. We actually sent them our version. It's been great. They have a new leadership team. We've had great conversation. They sent us their version back. I will also note, per the BRFA, the way that it's written, the county pays for half and then the state would cover the other half. So this is actually for half of the,
50%.
so yeah, so this would be half of the team and then the state would fund an additional 4 positions. But what everybody needs to know is that the training process takes about a year. So even if we hired them and had the PIN and all of that worked out July 1, they're not going to start inspecting until July 1 of 2027.
Oh, okay, okay.
But just, I don't want to. Usually we have to catch up with whatever that is to annualize those positions. So if we're 6 years, that means that for us, our commitment of the 5 would be approximately $800,000 or close to $900,000 if we consider compensation adjustment, because they would have to be annualized. I'm not saying that we shouldn't. I just want to be clear about, but I think this is what it is, like I said, is that because we don't have the MOU, we don't know what the amount of funding is. You're saying that we would maintain 5 FTEs, and then when we got confirmation from the state that we would be able to add an additional 5 FTEs?
So, yeah, to clarify here, that the amount in this budget is half of the cost for a full year, with the anticipation that it would take us about 6 months to onboard the individuals, and then we would have costs for 6 months. The county would bear 100% of the cost of those individuals those 6 months while we were training them, because they're not capable of taking anything off the plate of the state inspectors. In fact, the state would be contributing staff to train our staff.
Okay.
At the conclusion of FY27, in and do 50% of the inspections, investigations, and so on, would give Montgomery County greater impact and oversight of this happening, ensuring that these are happening at all of our nursing homes. And at that point, the state would pick up 50% of those costs. So the FY28 cost would be very similar to this budget cost for the full year instead of for half of the year.
Okay, thank you for that. And do we have an understanding of how many facilities we have across Montgomery County?
35 nursing homes.
Okay, all right. And do we know how up to date the state is with all of those inspections? How was that information communicated to the county?
I believe they're fairly up to date. There was a March update at the Maryland General Assembly, and I believe they said they were 80 to 85%. I can make sure that information was included in the packet, but they gave an update at that time, and they actually talked about the MOU with Montgomery County. So they pretty much said that they were up to date. But I will provide the exact percentage of what the state said at that time.
Okay, and so is this just DPS involved at all?
Just HHS.
Okay, so if a facility is inspected and they are found to have a code issue, what are the fees associated with repeated violations?
So I believe there are some fees for having to do repeat inspections.
Okay.
But I don't, that the state collects those. Yeah, we.
But I mean, if we're shifting, is that going to be addressed in this new MOU?
So
who's leading this MOU discussion?
Sean and myself. And so the state basically the MOU would delegate the authority from the state to the county for half. Kenny, I don't know if you want to come up and talk about you don't have to, but.
The way that these happen is there's a required annual inspection. On top of that, there can be revisits because things were found in the inspection.
Yes.
There can be investigative complaints that range from life safety all along, and depending on the urgency of it, you'd go back, initiate that within 10 days or the next time you're there. Sometimes if it's a lower level complaint, it may get wrapped into the annual inspection. Those inspections The full inspection is typically done with a team of 4 people who go in for several days. It could be more than a week, depending on the size. Our nursing homes range.
It's about if, there are code violations found and our paid employees have to go back. That's staff time, that's, more work. Are we collecting, or is this money going to the state and they're only paying for half of these positions? So I just want to know who's collecting the revenue on the reinspection.
Yeah, Kenny Welch would like. So it's a federal program that's passed down to the state. It's CMS. And so any penalties would go through the state back to the federal government. We would not be collecting any penalties on any violations that occur. The penalties are like $100,000. So it's not something that the state would incur back to the
But how do we factor that into re-inspections? Like, is that not discussed in the MOU with regards to the salary or reimbursements? Because that takes away from staff time. So I'm just wondering if that's something that could be discussed, or is that just a
the
standard
re-inspections
process?
Job. It's
So there's nothing that we could enforce or collect locally?
no.
Okay.
And again, the state has this authority delegated from CMS to the state, and in this case, they would be delegating it to us to do it on their behalf.
Okay. All right. So without objection.
What is the vote? Is the vote for?
Consensus to add it to the records.
Reconciliation.
Yes.
Okay, thank you. And I'll just note, because I mentioned the Office of Healthcare Quality met February 2026 with the state. They have fulfilled a backlog between 2023 and 2025 of 335 inspections. So their progress was that as of January 2026, there have been a 90% reduction in the backlog. They did not designate the areas, but there was 12 outstanding surveys as of January 2026, and they expected those to be complete in March of 2026.
Okay.
So that is the latest update.
Thank you. Thank you.
Okay, moving on to item 1.10 on,
Speak at full council. Thank you. Go ahead.
okay. Moving on to item 1.10, starting at the end of page 17, is to continue services despite the Ryan White Part A grant reduction. This was for a 1 FTE supporting 300 and would be $362 on $362,122. So there is a description of the, on page 18, there is a description of the positions that this would fill. So it's 1 FTE, but 3 contractual positions. Ryan White funding is related to the HIV/AIDS program, a federal initiative administered by the HRSA to support a comprehensive service of care for people living with HIV who are uninsured or underinsured. The county has operated this program for a very in the grant due to federal changes. If you see on the bottom of page 18, it is mapping out the Ryan White funding and the reduction that they have seen over the past years, approximately since FY25. There has been an ongoing reduction. And on page 19, there is data on the number of clients served for FY24 and FY24. Staff recommendation was to concur with the executive's recommendation so that HIV services to county residents are not reduced.
Okay. And these positions are providing STI and HIV testing in our clinics at no charge to residents?
Correct. We can't bill for those services.
Yeah.
They also help support our oral health services for our HIV positive. Help with the care coordination for both medical and non-medical care coordination. So with SDOH needs as well.
Okay. And are any of these positions that currently exist supporting our Pride Center and their STI and HIV testing?
I'm sure that they come and do Pride Center events. I would ask the team.
Because I know that they do that.
Yes.
Same specialists or not.
Yeah, they have a broad team and that scheduling varies by month, but yeah. So I should say that it's not these positions that are exclusively supporting the Pride Center testing. They, members of the team might support it one month and then they might be at a different outreach event the next month, if that makes sense.
Okay, all right. So without objection.
There's consensus among the three. Just one. 11 on page 19. This is for the statewide integrated health improvement strategy home visiting expansion grant reduction. This request is supplementing the loss of the funds of the state funds for the Babies Born Healthy program. The request is for $201,905, and this would be 1.5 FTEs. The the committee heard earlier from this year during the OLO update on the racial disparities and Montgomery County report. There was a lot of detail provided about Babies Born Healthy and the work that they do within the department in supporting our county residents. So the Babies Born Healthy program experienced a reduction in funding due to the elimination of the expansion grant. As a result, the program will be unable to retain 2 positions, a part-time community health nurse and a full-time health educator. I would assume that these positions are the same thing where they're merit positions but term because they are grant funded. DHS estimates that approximately 75 women will be unable to receive services as a result of the reduced staff and funding levels. This reduction would also limit the availability of case management and supportive services provided to program residents. There is a description of the work that those 2 positions do on page 20 onto page 21, and council staff recommendation is to concur with the executive's recommendation.
Without objection. There's consensus.
Okay.
Yes.
Moving on to item 1.12. Under the Cancer and Tobacco Program, the retail tobacco enforcement capacity, this assumes a January 2027 start date, $77,561 for a 1 FTE. As mentioned earlier, this should be treated similar to the TB program, as the new laws related to tobacco enforcement requires the county to provide enforcement in the county. So this would be a new program manager 2 FTE to support the enhanced level of enforcement that is required by the county. There's detail on page 22 about the state performance measurements and the estimates for the award period. And in FY25, there were total compliance checks of 100. In FY26 year to date, there have been 147 compliance checks.
Without objection.
Can you let them finish though? Before,
Oh, okay.
I think that's. I just want to say, because we've had this happen. Staff before we tell them what the will of the committee is.
Thank you. Ms. Ludke?
Just briefly, I will note that alcohol beverage services previously issued citations, but in FY23, ABS informed DHHS that would no longer have the capacity to do that. So along with the program and DHHS having to assume the state's new regulations in terms of enforcement, there is recommendation to concur with the executive's recommendation to add the position.
Without objection. Thank you.
Okay. So we are moving on to other budget changes, so not considered for the rec list, but these are for the committee can certainly weigh in terms of if they agree with them or not.
Do you want to vote as a block, or do you want to go through each line item for public health services changes? These are not going to the rec list, increases and decreases.
Correct. There are 3 items
Yes.
that cross pages 22 through 24, and then we would skip to page I believe it's 29, I'll tell you, so we can talk about the request
You
from the
can just go
college
through them,
members.
just so everyone's clear on what we are voting for.
Okay, well, the 2.1 on page 22 is to continue to backfill the TB program and annualize the supplemental that was approved in FY26. This is $170,000 to maintain TB services within the county. Mr. O'Donnell talked through the details of the TB program, but basically there was a reduction of the grant from $170,000 to $25,000. This reduction was significant, so mid-year, the council voted to approve a supplemental appropriation to continue to provide the services. The executive's recommendation acknowledges that this reduction is supposed to continue so that the additional funds are needed to continue providing the services.
Without
All in
objection.
agreement? Great. So for 2.2, hospice volunteer training services, this is a reduction of $17,715. This reduction is related to underutilized funds or savings in the hospice volunteer training program. This program originally started to help support the county's HIV care and case management program. The county's contractor, Caring Matters, provide this training twice. I think the next training is September of 2026. So this minimal reduction is just recognizing the underutilizations of the funds and savings that the department can capture. And so the staff's recommendation was to concur with the CE's recommendation.
Without objection.
And lastly, for public health services, there is a reduction of $27,715 as noted on page 24. This was part of funding that was used to supplement the medical reserve corps position. That position was contracted and did. But this reduction is really due to the underutilization with the cost of hiring a contractor to perform those services. Council staff's recommendation was to concur with the CE's recommendation.
Without objection.
Okay. So we will skip to page, page 29.
I'm sorry. We're going to go through the budget. Okay. We're just going to go through unless there's an opposition with putting it on the county executive's recommendation. Is it in opposition to the county executive? Okay, so we're not going to take any questions until after she goes through the entire list. And then we can talk about the memos, and if you have questions, we can go back to it. But I want her to go through. Thank you. Okay, go ahead.
Okay, so we are going to page 29 to discuss the memos requested for public health services. We will go revisit the MHIPs, but we just want to finish out public health services.
Yes.
So the first memo received was from Councilmember Stewart requesting 2 tranches of $250,000 for the Montgomery County Pride contract. Starting on the bottom of page 29 and onto page 30, there is a request that that funding be added to the FY27 operating budget to match the funds that were approved in FY26 from the base. So page 30 provides additional background about the about DHHS.
I'm sorry, Ms. Clemens Johnson.
Yes.
We are finishing the public health services, and then we will get to the MHIPs.
Correct. This is still the Public Health Services Amendment. The Montgomery County Pride contract is operated by Public Health Services.
Oh, okay, I just thought that was at the end after.
MHIPs are actually not part of public health services. They were lumped with this packet, but they're not in public health services service area. They're in the director's office. So,
yeah. So we were trying to make sure, because the timing and when we received things and how the creation was of the packet was after the fact, and so as part of public health services, the memos that have been received are so for the Montgomery County Pride contract, for the Muslim Community Clinic oral health contract, and for the amendment for the American Diversity Group. Those 3 contracts lie under public health services. So there is the recommendation that we talk about those 2 memos and the amendment because they are part of public health services, and then we would move on to the MHIPs discussion.
Okay, did we finish the, oh, yes, okay, all right.
Yes,
Okay.
so that's why I apologize that the packet
Okay.
is just the timing and when we received the information and
Yes.
wanted to make sure that it was at least reflected.
Okay.
So
So
we are going to page 29, which
Okay.
Okay. So, as noted, we are talking about the memorandum received from Councilmember Stewart for the Montgomery County Pride contract administered by Public Health Services. There is a request for 2 tranches of $250,000 or a $500,000 request overall. This request is aligning with the FY26 contract amount that was approved through the base budget in initially of $500,000, and then there was a special appropriation of $500,000 that took the contract amount to $1 million. On page 30, there is additional background about the department's relationship with the Montgomery County Pride Center. I won't go through all of that background, but I think this appropriation is just noting that there was $1 million allocated to the Montgomery County Pride contract in FY26, and this is the effort from Councilmember Stewart to maintain the same funding that was received by the organization in FY26. Without this additional funding, they would go back to their base amount in FY26, which was $500,000.
Thank you for that. And I didn't see a breakdown of the current year. I believe in the packet it said, was it 80 or 90% of the $1 million is on staff salaries? 900?
Yes, if, on page 30, if you look to the
Yes.
second to last budget,
Okay.
it states the FY26 Montgomery County Pride contract of $1 million was largely used for personnel. The contract split of funding was $900,000 allocated to operating.
Okay, and do we know what services and how many people were served by the Pride Center? Was it testing? Because we didn't receive any information.
Yes, we can get you that information and follow up. They've started submitting monthly reports as of February. So we will get you that information, Councilmember
Okay.
Scales.
And so before February, I mean, this was awarded in the county executive's FY26 budget, and I'm sure it had some scope of services or expectation of services. And so can you include that as well in the packet?
Yes, I can. And their services include a number of different support groups.
Yeah, I see it
transparent
in
things.
the bulleted
Yep.
portion.
I will get you that.
Okay, all right, thank you. Councilmember Friedson.
Yeah, well, I've been a big supporter of the Pride Center. I'm proud of the fact that it is housed in District 1. I can walk there. I have walked there on many occasions. They're doing some really important programming, but they're also doing work all around the county as well. That's just the hub. I'm supportive of adding this to the rec list and, us working through it. I think 2 tranches makes sense. I do just think there is a disconnect between commitments that have been made or the belief of commitments that have been made, or a discrepancy between what I believe the guidance that the department has and conversations at the political level in the executive branch. I'm trying to be as charitable here as possible, but this has made it extremely difficult for us to navigate through this. And at a certain point, and I would beg, sooner, like tomorrow or later, there needs to be an agreement of what the county's role and what the expectations for this organization are going to be moving forward. I don't think it's been fair to them. I don't think it's been fair to the council, who has not been privy to some of these conversations. And it's coming from someone who is a massive supporter of this organization, who has worked together with colleagues on emergency appropriations and others. But it seems increasingly clear that certain commitments have been made in certain conversations, and then those commitments haven't been communicated, and it's not fair to you as a department. So I'm not even really asking for a response, because I'm not sure that you'll have one, but I am asking specifically to be conversations, and whatever those conversations are, the department has to be privy to those conversations, or else it's not reasonable or fair to move forward. So this is my public call. I've called for this privately. That has not worked, obviously, because it's continuing to happen. But we're increasingly getting frustration from an organization who has been told one thing, and then a department that I don't think has been receiving that message, and then, ultimately decisions made, and actions and questions and, positions that the council's been put in as a result.
So thank you, Councilmember Friedson. I want to thank Councilmember Stewart for her memo and recommendation. Council, the committee is in agreement with that.
Two different tranches, and we'll work it all out. I also want to thank Councilmember Stewart for trying to mediate. What I will say has been, to Councilmember Friedson's point, a challenge of who said what and when, and also, sort of raised the flag of sometimes people rely on a thing that is said in passing, or the handshake, deal, which is not a contract, which is still not approved. That's a problem. But that also, when someone in a position of authority makes statements, it makes them feel like they could rely on them. And so you understand how we got to this situation. I just would like it to not happen moving forward, so that everyone's on the same sheet of music, and, that HHS says yes or no, and unless and until someone has heard from HHS, and then a decision point has not been made, or a financing point has not been made. Dr. Ashford?
I just want to know, as the department, our job is to execute the contract.
Right.
We don't have a decision over funding.
Right.
We, support the county executive's budget. We make sure that it is in line with county procurement policies.
Right.
That is what we do.
Right, and those are what the contracts are, operational decisions of the agency. So to the extent that a change in an operational decision is to be made, they are the operational decisions of the agency about the scope of a contract. Then if it needs funding to execute it, you come to council to get the funding. And somehow we need an infographic for how we got here, but somehow in all of this, there's been a disconnect about that contractual process, which is fundamental to the underlying issue and why folks keep finding themselves at an impasse. And I did want to double check, because it's true, the Pride Center does a lot of things that are not just done at the physical location in Bethesda. And so to the extent that the salaries portion of the funding was referenced as being 90% of the funding they've received in FY26. Does that include the grants that they're giving out to do the other programming in the other spaces, or are the grants in the other 100,000 that is for programming?
I didn't know they were giving out grants, but
yeah. Or they misphrasing it, but that they have. Mr. Hodge, can you fix it?
I think I will have an answer.
Thank you.
So, $1 million from the county to provide services. 90% of those do end up being staff costs and personnel costs for a large variety of employees that they have. The $100,000 that is in, it's a little bit more than $100,000, but the $100,000 that's in the operations are through other subcontracts that they have. So they're not giving grants. So they do
subcontracts.
Right, so yeah, so they do drag story hour in the libraries.
Right.
They do the Pride Festival in Potomac. I mean, sorry, not Potomac, in Poolsville. And a handful of other groups that they do.
Right.
The issue that the department has, and why I came to the table, is because I want to just defend the department a little bit in this. We, as the contractor, as an HHS, Health and Human Services agency, would have preferred to be able to do a contract with this organization to do health and human services. When we continue to push for that, and even with the additional $500,000 to push on getting more health and human services through that contract, the response from the organization is which is fine. So now if the county is opening a community center for the LGBTQ population, which I think is amazing and greatly needed, especially because we know that 1/3 of the population they serve are outside of Montgomery County.
Right.
So there's a need, at least regionally, for something to happen. And the services they're providing, however, they're not health and human services. And so when we push for this, when we were looking at, would we cut this to go back to the base budget, or would we want to advocate for the additional $500,000? We erred on the side of cutting it because it's not providing any services. It's just paying a large number of people's salaries, including the executive director of a statewide Trans Maryland program. So, which is all well and good for a community center, for an HHS contract. We've tried to steer it towards what we would like and have been unsuccessful. The politics around that, outside of what we're trying to do, we want this, we would like services to be provided that are related to what we do.
Gotcha.
And have been unsuccessful.
No, thank you.
Yeah.
Thank you, Mr. Hodge. That was very, very helpful. Thank you.
Thank you. So before this comes to full council, I think the scope of what services were expected to happen through this appropriation of $1 million, and then what money has been spent year to date and what that has been spent on before we bring this to council. And we did confirm that they did get the $500,000 from the state of Maryland, and they were appropriated the remaining $500,000 from FY26 during our emergency appropriation in November. Okay, let's move.
Yeah, well, could I just quickly, it would be helpful for me to understand what is the scope of a health and human service, because in some contexts, I feel like we are very broad in what health and human services entails and includes, and I think in other contexts, we're very specific, and I think that's reasonable. Since this is in the public health space, that's more specific than the broader health and human services. This is a sprawling agency that does a lot of stuff, and so it would be helpful for me, just in fairness to that statement, which I appreciate you speaking the truth on your perspective and standing up for the department, and I understand where you're coming from, but I also want to understand what we mean when we say a health and human service and getting to doing those services. So if you could just give us that scope of exactly what you mean, of here's what we want to happen in a contract, here's what's not happening, here's why we think if this is going to be funded, it should be funded in a different department, not in ours, because we do a certain thing. I'd like to know where that begins and
You can follow.
Okay, well, I have the floor. I'm just trying to finish my point. Thank you. That would be helpful. Thank you.
Sure. Thank you, Councilmember Friedson. We have information on the intersectionality of health and human services.
Thank you. So it looks like we had one more memo item.
Yes, and so just to revisit for the public is that there is consensus that amongst the $50,000 to the rec list, and we will provide the additional information.
All right, thank you.
Moving on to memorandum from Councilmember Mink on page 30 of your packet, and circle number 13 of the actual memorandum is the request for the Montgomery Care subcontract Muslim Community Clinic Oral Health Center, $118,000. Councilmember Mink is requesting that there's actually a correction to the number. Sorry, my papers are everywhere. So was a memo that was transmitted basically requesting additional dentistry funding for the Muslim Community Clinic. There was recognition that since 2014, the MCC clinic has provided dental services to county residents through a contract with the PCC under the Montgomery Cares umbrella. The initial contract was $168,000 annually, and there has not been an increase. Council staff notes that in the memorandum, the request was parity with the other Montgomery Cares oral health provider contracts in terms of dollars. Charities, because they also provide oral health services under Montgomery Cares. So the corrected amount of this increase would be $135,548.20 if this is approved. Just wanted to note that it was not the 118,000. And I will stop there since Councilmember Mink is present.
Councilmember Mink.
Thank you. Yes, and thank you for that updated number. That's certainly the intent there is to request parity in terms of dollars. I'll note that it's parity in terms of dollars because it's not parity in terms of the number of folks that they are serving. They are the largest provider of the two in terms of patients served and services delivered. Both of our providers are working really, really hard to provide service to this very vulnerable population. And the Muslim Community Center has been trying really hard to leverage private fundraising dollars to close the significant gap that has between the funding and what the need is. But that is not sustainable, and we are really at a tipping point. And so they are asking for really what they should be getting, which is parity with the other dental provider. So appreciate the committee's consideration.
Without objection. Thank you.
Thank you. There is one more item to consider, and that is the amendment for public health services. That is the amendment received by the executive on April 21st. This is for the American Diversity Group Clinic in the amount of $202,600. This is the information supporting or providing context to this request is on page 31 of your packet. The executive in his amendment stated that I recommend $202,600 to continue to support a free clinic for medical care screenings and treatments with a focus on chronic disease management, preventative care, and general health services for vulnerable populations. So as part of the updates to your packet, council staff had requested an update on the American Diversity Group recognizing the $202,000. So there is 31, 32, and 33 of your packet. I will leave it there and request a vote of the committee of yay or nay.
Yay. Yes, we're all very supportive of the work that they're doing.
Okay, so that is a wrap up of all of the budget items and recommendations and amendments for the public health service budget area.
Thank you. I thought you submitted it for the MHITs. That's what the minority health.
Thank you. I just want to acknowledge for the committee the time. It is currently 12:40. We would be beginning the MHIPS discussion.
We're going to power through. Yes.
Okay.
Let's
all right.
Yes.
We will start. So the MHIPs do have a presentation. I have been told that they can keep it brief.
Keep it brief.
Okay. I think IT might need to.
How many slides do you have?
8 slides, but
okay, perfect.
Chair Sells, I'm going to turn it over to Mr. Hodge. Let me make some opening remarks. I have a meeting with the county executive at 1 o'clock. During our session on the last Thursday, we have reviewed the testimony. We appreciate our partners who have voiced their concerns about any of the program initiatives. Our team has addressed those concerns, and we continue to address those concerns. What you will be presented with this afternoon is an overview that speaks to the budget part of this packet, and I'll leave it there, and we can start the presentation.
Let's start this presentation, please.
I need someone from IT to help reset the computer.
IT, we need some assistance, please. And just to be clear, when did we have our last MHIP meeting briefing?
I believe the date was, thank you, it was March 5th.
March 5th, okay. And then we had quite a few requests of the MHIPs. Were those received, Tara? At the end of that meeting, I believe each of us had some additional information that we requested.
Yes, The additional information was specifically that I can recall was information from the it was the Asian American Health Initiative. We did send that memo out to the committee. We received it, I believe it was that
Well, I think
Friday.
it was across all committees about their, just standardizing the expectations. And I didn't know if we were saving that for another meeting because it wasn't in the packet, but it was requested at the conclusion of their presentations.
I believe anything else we were talking about was what talked about in the context of a meeting about like them
Okay,
getting
yes,
together
yeah.
and talking about. There was immediate feedback that I said. I
Oh,
believe that
good.
was provided by Mr. Hassan. Yes, and so that was sent out to the committee after the fact. But I think the request was more of like a long term.
Yes.
And I believe actually the team was going to talk about that today, about how
Yes.
they are
Okay.
trying to work together to more as a collective,
Good.
especially with the reorganization that has happened with the
Yes.
MHIPs into the director's office.
All right.
So for reference, in your packet starts on page 24, that there are specific, there are recommendations outside of, no, I don't believe there's recommendation. The only recommendation that's outside of what the executive has is the memo from Councilmember Meek about the Vietnamese Association. And we can talk about that after we talk about the executive's recommended changes. I don't know if,
I'm seeing if Sarah's able to. Do you want to skip to your memo since we don't have technical support? Okay.
because actually there are no recommended increases, so anything, so there are no county executive recommended increases that would go on the reconciliation list. So the unless you vote to change the other items recommended, would be Councilmember's memo. So that memo states that it was received on April 22nd, and it was noted that in the April 23rd, the memo states that in April 23rd committee session, that we will review a proposed elimination of $92,638 in the contract with the Maryland Vietnamese Mutual Association. Seeing as though this memo impacts a recommended budget item, do we want to talk about that recommended budget
Yes,
item
please.
briefly before we talk? Okay.
Yeah.
I think that would be helpful to give a bit more context. So if we go to page 27 in your packet, it is item 2.4. This says tutoring services for youth and senior wellness services for centers in the Vietnamese community and transition a non-competitive contract to the Healthy Community Funds Grant Program. So the executive is recommending an elimination of the Maryland Vietnamese Mutual Association contract. I'll refer to them as NVMA for the sake of this discussion, of $92,638 and transition the program to the Healthy Communities Fund. So the Healthy Communities Fund was transitioned actually to the Office of Grants Management in FY26. It used to be administered by a nonprofit, but noting our office, the request of the department to recoup like indirect and operational funds that would no longer be needed with the Office of Grants Management doing that work. So the fund in FY26, the grant supported awards up to $150,000. The awardees were not available at the time that this packet was created, but hopefully the Office of Grants Management can provide us that update when it goes to full council. I will note for FY27, the HCF grant will transition to a higher threshold for applicants with the maximum ceiling of $250,000. So based on this change, the department is recommending that the MVMA contracted be eliminated. It's noting that they have historically received a HSCF grant for around $150,000, and they also had a contract with the county for $92,000. So even if if the contract is eliminated and they still apply for the same grant, that they could still get the same funding, but it would be under grant, a grant program instead of a contract. Yeah, so the council staff's recommendation was to concur with the county executive's recommendation.
Did the HHS want to talk to this, the county executive's recommended cut before I turn it over to Councilmember Mink?
Sure, I'm Mohammed Hassan. I'm the program manager with the Asian American Health Initiative. So this contract focuses on tutoring services for youth and youth tutoring and mentoring services for youth and senior wellness services for the Vietnamese American community. The idea is this has been a non-compete contract since I think FY 2010. The idea is at that time we didn't have a competitive grants program. We started that program 4 years ago, and now the idea is the funds that AHI has, all those funds are through competitive grants processes where programs and services are funded based on need and the best practices that can be used to address those needs. The two components of this contract, the youth tutoring and mentoring services, are beyond the scope of AHI's primary mission, which is health and wellness. The senior wellness services that are funded through this contract can still be provided by the HCF-funded organizations. Of the 16 organizations we fund, 9 of them provide senior wellness services. And then we also have a patient navigator program that also is a multilingual case navigation program that can provide these services until November 2027, when HCF 2027 will be competed for. And as Tara said, the idea is to, because MVMA has historically received around $150,000 through the HCF funds and $92,000 through this contract, by increasing the maximum cap to $250,000, they have a potential to compete for these services.
Thank you. And Councilmember Mink?
Thank you. I just want to clarify, so the contract is not for senior wellness services. The contract, the senior wellness services are already grant funded under the HCF grant. That's what's suggested to transition. There, as noted, MVMA is funded in 2 ways by the county. The 150 approximately K, which they compete for under the HCF grant, and the smaller, the $92,000 contract, non-competitive contract. They are already competing with the senior wellness services for that contract or for that opportunity. That's already under HCF. The contract, which we're discussing today and which is proposed to be eliminated, that is for youth tutoring services, is a small part of the services that they provide. But primarily what it does, and I will read here from the FY26 operating budget, is provide low-income residents with limited English proficiency and other translation services, assist Montgomery County residents with SNAP, energy assistance, Social Security, and immigration applications. So primarily what this contract is doing in terms of its senior services is connecting them to supports and bringing in federal dollars through Medicare and Medicaid. We are bringing in substantially more, hundreds of thousands of dollars are being brought into this county to some of our most vulnerable residents, seniors with very limited English, and I can speak to that because I have spent time in rooms with many of them, and I need those translation services when I'm there with them, assisting them with bringing in those federal dollars, which alleviates strain on our already significantly burdened social safety net here that's funded by the county. They also help these seniors to do things like apply for rental assistance, to understand rental agreements that they're signing, to get driver's licenses, things of that sort. So, and this is not something that's going to be easily done by somebody else because there's a language issue, there's a cultural issue. MVMA has spent years cultivating trust and relationship within this community. We have multiple times, this council has seen this room full of seniors with the little earbuds in to be able to understand the proceedings. I have parents who are seniors. I have a parent who is an Asian senior, and I will say it is not easy to get her involved in politics or to get her to come and engage in this way. But we can see the motivation. They turn out to make sure that this funding is available for them. And this would actually cost the county money to cut this contract. I do want to appreciate HHS's responsiveness to our conversation last year in terms of raising that cap. Last year, when this contract was proposed to be eliminated and that it be shifted and that they apply for it under the HCF as well, that was actually impossible. That couldn't have been done because of the cap and maintain those services. Now that cap has been raised. However, the problem logistically with that, not only I would say would we be eliminating a line item that again is bringing in far more than we're spending, but additionally that contract, because those funds through the grant were not delivered until the end of November, beginning of December, that contract, that annual contract, they would not be able to expand the scope of that until after November 30th. So there would be, even if we were assured that they were going to win that expansion and win that funding through the grant process, there would be a gap in services, and I appreciate the conversation about that yesterday, Mr. Hodge. So I would ask the committee to restore this. This is an investment that, again, brings far more dollars into our county than otherwise would be there, and it is an important investment. And if we do not fund it, there will be a gap in services, again, because the scope of that grant cannot be expanded until the end of this calendar year.
Go ahead. Thank you, Councilmember Mink.
So according to the contractual scope, the original contract was focused on parenting, enrichment, and youth program. The second part was the GAPS program, which is the senior wellness service that you provide that helped them enroll into social care services. The third part was the immigration component, but the contract was amended in FY 2014, where the immigration component was taken away, and contractually, the parenting enrichment program turned into youth mentoring and tutoring services, and the senior wellness services were maintained. The senior wellness component of assisting seniors to access social services, that part is duplicated with other grantees. So as I mentioned, 16 of the organizations funded through 2026. 9 of them are providing senior wellness services. About, I think, 6 of them are providing case management services, in addition to our patient navigator program, which is a multilingual information and referral line and a case navigation line, where the navigators receive the calls and can respond in the languages of the resident. They can connect them to resources, and if they need assistance to physically go and apply for services, they'll offer that service as well. So that's included in our patient navigator program. Year to date, if we look at the data that we have received on the contract, the majority or nearly all of the seniors that have been served through this program have insurance, either through public insurance or private insurance. So I just wanted to clarify that.
And you said 9 other programs are providing support for the seniors?
So the HCF Grants Program has 3 funding categories. One of them is senior wellness. And of the 16 organizations we fund, 9 of them provide senior wellness services. And then I think it was 6 of them that also offer case navigation services, similar to what MBMA is offering through this contract.
Okay. And of the 9, how many provide services for seniors in Vietnamese?
I will have to get back to you from memory. 2 of them definitely provided, and then a few of them are multiracial, so they can offer services to a wide variety of community members.
Okay, what's the pleasure of the council? I'm fine with, yes, without objection. Thank you. Thank you, Councilmember Mink.
All right, that will be added to the rec list per the approval of the consensus of the committee. The slides are up. Would you like to revisit the slides and give the opportunity for the department to?
Yeah, they said there's 8 slides.
Okay.
Yes, we'll go through those pretty quickly. Who's going to get us started?
Maybe slightly more than 8 slides, but I'll try to go through them quickly.
Is it 8 slides total? Okay, come on. We're gonna power through it. We have very limited time, so.
Okay. So I'll skip through it.
Yes.
Hit the highlights. All right. So this is the mission vision you're aware of. I'll skip through that. The impact is basically we do direct outreach, we care navigation, and we're aimed at reducing disparities through stigma reduction and education. The next slide is numbers. Here I would just focus on 3 metrics that we have started to capture in FY26. Of the 6,000 county residents that are uninsured, our programs serve 1,000 of them, which is 16%. Of the over 9,000 Asian residents that rely on SNAP, we serve 25% through our programs. And of the 2,678 Asian seniors below the federal poverty level, we're serving 28%. Program areas, we talked about this in the March meeting, so I'll skip through that too. And then our second budget ask is for the transition from broker to merit positions. There are 2 programs we're talking about. The community health worker program. This is right now, it's through brokers. By having merit staff, will reduce turnover, improve retention, and the end goal of sustained infrastructure and maintaining service continuity. The ask is for 2.5 FTEs. The other is the grants administrator role. This sort of concludes our conversion of or our transition of the Healthy Communities Fund program from a contract to OGM, and this is the last step, is the merit position that supports the administration. That's 1 FTE. It's a cost neutral effect, and the precedence is all existing merit position at AHI and LHI were previously converted from contract to merit, and it led to cost savings and built institutional knowledge. The last slide is the MBA one, which we already talked about, so I'll hand it over to Mariana.
Fast, but I will try my very all the portfolios for the are culturally and linguistically competent, serving the Latino community in a variety of ways. Next. Thank you. Your attention to what I think is one of our best assets in the community. We were able to engage with 70,000 community members in person through 850 events. And this is through our programs and also the work of the community health workers that reach 47,000 community members. And in conjunction with our social and digital media efforts, we were able to reach 435,000 community members. So I think it's a very good way to get the information out in the community and also to collaborate through HHS. Thank you. For next year, FY27, we are really excited to expand our services in due to demand. We have our Golden Years. That is a program designed for seniors 65 and up. The program was planned for 25 seniors, but we have a consistent attendance of 50 seniors per event. So we look forward to expand that, and also our Parents in Action, that is the only substance abuse and alcohol education program for parents of elementary schools. We have 4 cohorts, but there is an increase in demand, so we would like to expand. And the LHI will be conducting the Latino Health Needs Assessment to develop the blueprint for 2026-2037. Thank you. We have 2 recommended reductions in the budget for FY27 from the county executive. The first one is a reduction in case management services. The reduction is for $537,000. The reduction was determined based on the needs of the community. The LHI case management services provide navigation and referral services to Health and Human Services, and the county also have through HHS the Lighthouse program that their services are comparable to the LHI case management services. The only difference is the legal support and housing services, and we are through our work with our vendor, we are realizing that the majority, up to 50% of the participants in the case management services at the LHI have legal and housing services. So we have implemented a pre-screening protocol in which when the client comes by assessment, we determine which program will better serve their needs. And the next one is the reduction of the health information line. There has been, the information line provides information and referrals to the county and other community services in Spanish and English and French, 5 days a week. And for the last couple of years, there has been a steady decline in the numbers of calls to the helpline and in the number of referrals. However, there has been an emergent need that has to do with rapid response calls, but the rapid response calls are not aligned with the current scope of work that the LHI has for this contract. So I understand that there is an amendment that will be discussed later in the package that will be able to address the rapid response calls and maintain the reduction for the line regular calls. Thank you.
Good afternoon, Wani Dixon, Program Manager for the African American Health Program. I will also go fast. So just a quick review, this is our mission. We're eliminating health disparities. Just a quick reminder of who we are. We can go to the next slide, please. This is just and just a quick overview of some of the statistics and successes we've had in FY25. This is just a demonstration of where we are, where we're going, and how we can continue to grow and to expand our services. Next slide, please. We've managed to achieve all these successes by really being trusted in the community. We've got strong outreach. We rely heavily on our culturally responsive services, and all this has really led to our measurable improvements, actually, in our key health areas. And as we continue to grow and expand, go to the next slide, please. Yep. This is probably the most important slide that I wanted to share with you today. This really explains why we feel like why where we are in terms of growth and where the program is going. We have demonstrated successful results, but extended services does not equate to program growth. We should really invest in the capacity of the program so that we can continue to be sustainable, cost efficient, continue to be responsive and innovative in how we show up for the community. And also, as we think about change, nothing internally is changing in terms of our services. We are just adding 4 key staff, who I'll go over those positions in a little bit, but that will help to increase our capacity in our data analysis, our program performances, and add an additional layer of oversight and alignment between the county and the program, and also broader public health goals. And most importantly, I think this is really where we leverage the HHS infrastructure and capabilities and knowledge, and combined with our community-based service deliveries to enhance our flexibility, again, deliver on our services, and also go beyond a primary vendor, where we can begin to expand and work with other partners, perhaps grassroots partners who are in places where we are not in the county. We know that we have gaps in awareness and gaps in just certain demographics in the neighborhood, and that is not a criticism, that is just a fact, because we don't have all of the data that we need, and we are working to get to that point to collect our data so we can make more data-driven decisions and thereby increase the impact in the county, and also remain accountable to our community, remain accountable to county council and the continued investment, and also to ourselves. As we continue to adapt and grow. So we'll go to the next slide. So we are asking for 4 positions. I apologize for it being so small. It didn't look this small when I looked at it. I apologize. But the 4 positions that we are asking for, and this is the major ask for this year, is the manager 3, and this role, although there's a program manager, me right now, this manager 3 position would, because of the growth in this staff, that person would continue to lead the strategic vision of the program along with the executive committee and make sure that we are aligned with county priorities and operating with accountability at the program level. The second position is the maternal health nurse lead. I will say this position currently exists in the contractor's side right now, in the vendor side right now. But the importance of bringing this into the county is to create a stronger alignment between maternal health services and the broader public health system. So that is why we prioritize bringing this one into DHHS as a merit staff. The third position is the data analyst role, which will allow us to identify gaps, as I said, that exist in awareness, engagement, and outcomes, and use that information to guide strategy. Currently, there is no data analyst on either side. And this is a key need. This is probably the most important one that we need. And this will take us from broad outreach to more targeted data-informed action, which is where we need to go. And lastly, it's the program specialist 2 that will support communication, engagement, and coordination, and help ensure consistency and follow through across the program. Collectively, these 4 positions strengthen the program internally, but will also impact our service delivery in the sense that we will be more targeted, we will be more responsive, and we will be more nimble in how we move forward with the program. Next slide. Everything's so small here. So for us, FY27, really the most important thing is to invest in 3 parts of the program. It's our people, our systems, and our processes. The people, it's not just investing in adding more staff, but it's really about expanding our culturally responsive services to under engaged populations. And by that specifically, I mean our African and Caribbean residents, also residents who are in different parts of the county that we haven't reached yet. But that is how we want to strengthen our people. And in terms of our systems, continuing to leverage county systems to track our data, analyze our data, build dashboards so that we can visualize the data and answer these data questions that come up, constantly about what are the outcomes, what are you improving, where are you going? So investing in the systems and the capabilities to do that would really help the program grow and continue. And overall, our processes, as I said before, our targeted outreach is key, but we need the data to do that targeted outreach. How we also align with the public health system and maternal health and our other areas of DPP and CDMP, all will be data informed, all standardized to existing priorities where we are now, and then also strengthen that coordination between DHHS and all of our vendors that we will continue to work with. And next slide, I think this might be. So this is what we're asking for with the 4 staff. This is really part of a broader strategy that has been going on the past few years. My colleagues in LHI and AHI have gone through this process before of converting staff to merit staff, and all the programs have had amazing results in terms of expansion and service delivery. And as you've heard today, as they both talked about requested reductions, that is just an example of some of that responsiveness and how we continue to grow and evolve and respond in our programs. And so AHP's request for additional staff is just in line with the broader strategy and also aligns with already been done with the MHIPs. And next slide, I think this is the last one. This is just a quick reminder of all 3 programs and our asks. As you can see, we're adjusting our staff because we're focusing on internal capacity. There's also been some ask for reduction in contracts that is in result to looking at the performance of contract and more importantly, focusing on the needs of the programs, although needs continue to evolve. And collectively, we all have the same goals to address our health disparities in our various communities. We are all taking the same approach by being responsive in our various programs and looking at our existing capabilities and where we'd like to go. And that is where I will end, to be short. So thank you for that. Thank you very much.
All right. Thank you all for the speedy highlight and overview. Back to the agenda items. I know we all have a few questions regarding the items shared. And so I'll get started and turn things over to my colleagues. With regards to the AAHP program, do we have data analysts across all 3 MHIPs?
Good afternoon, everyone. Doreen Rosarian, DHHS. We do not presently. So the PMDA that we are requesting for
What is, I'm sorry,
the
no
data
acronyms.
analyst. So that's
Okay.
the official county designation for the data analyst.
Okay.
We anticipate having that individual, if approved, support the MHIPs broadly. So as Chief Hong mentioned in her earlier presentation, we have transitioned our data positions into Vantage and really blossoming our capacities in-house by having all of the data analysts increase their skills, learn from each other, really be able to leverage all of the learnings and knowledge across the department. So then really advancing our ability to respond to questions, leverage data, look at evaluation of their assigned programs. The same applies here. So we're requesting a PMDA to assist us. One, because we don't have that capacity within the MHIPs now, but 2, we want to share that across the various initiatives.
Oh, so that role will not just be specific to AAHP. It will be shared across all 3 MHIPs?
Yes, that is the intention, and we want to place it within the Vantage team. So following the pattern that we had that was approved in previous fiscal year for all of that skill set to be housed within the centralized location.
Right. And that matches the model that Vantage it has now with bringing all the data analysts all together from all of the different programs and service areas. While there may be one person is assigned to a program or a service area, they are working as part of a team, and so it's one person that we're requesting now for AHP that will work across all of the MHIPs, but also will have the support of all the other data analysts within Vantage. And so they're all working together, even though one person is taking the lead. They're all working together on this data analyst. So if one person's out, we don't miss out on. We're not missing out on all of that. We still have others who understand the role and the needs of that particular program from a data analysis standpoint. So that's why we're asking him for this particular program this one time. And if we need more in the future, I'm sure we will come back and ask.
And so how many data analysts do you currently have that are monitoring our MHIP programs?
So we have none that are assigned specifically to the MHIPs, but as data requests come in, we have Dr. Nemhard, who you've all met already, who's the manager for the Vantage, and her staff. She will assign individual tasks to her staff at that time. But especially during this time of the year when there's multiple requests for multiple service areas, we need all hands on deck. And that happens again for other performance times of the year. So having one person that's dedicated to this would be very effective for us.
And I know these programs, our MHIPs, how old are all of our MHIPs? How old are they? It's over a decade now?
They started back in 1999, and then I believe the first one was the African American Health Program.
Mm-hmm.
Then in 2000, it was LHI, and then a few years later, it was the creation of Asian American Health Initiative. So since 1999, what is that? 2009, 2019, around 30 years?
Yes.
So, yes.
Oh my gosh. Okay. Can we get the original scope? I don't know if it has evolved or changed. Are you able, has the scope of services for the MHIPs changed since its inception in 1999?
Each MHIP has a different mission, so they are.
I know they have a different mission. Scope of services. When we put contracts out, there's a scope of services that we request these contractors provide. So has that changed or evolved since 1999?
So the only MHIP right now that has a major contract that provides the most services is through the African American Health Program. And so all the other LHI and AHI have some smaller contracts, but the bulk of the work is done internally by the department. And so, and as is the case of the Asian American Health Initiative, they have a very large grant program that does the health services for that community in a much wider scope. So to look at the scope, there isn't one specifically except for what that has been since it was started until now. The scope has certainly changed a bit with the needs, but
Can you share that
for
with
an
the
MHIP? Yeah,
committee?
absolutely. But for the MHIPs generally, there isn't such a thing because we don't have large contracts that have spanned that lifetime of the programs.
And I just want to clarify that the AHP contract has always been an open solicitation contract. So people bid and then they are provided the award. And the contractor has changed over the years since its inception.
Okay, yeah. Would just be helpful to understand the scope of services that we're contracting for, because if we're getting a data analyst, it would be helpful to know how we are evaluating our contractors for their effectiveness and if they are complying with the services we're requesting. And then, so this staff member that is doing data analytics, is it coming from an AHP contract that's currently in existence, or are you recruiting externally for this?
If we get funding, if approved, we will create the position, because the funding already exists. If we create the position, recruit from the outside, so anyone can apply for that. One thing that I forgot to mention specific to this particular position is we are in the process of moving to a new electronic health record. Dr. Cloud is the vendor that we, as a department, not just for the MHIPs. But one of the things that we are moving towards, because we know that the services that the current McFarland Associates, the current vendor and partner for AHP, provides, especially around the SMILE program, a lot of those are billable encounters. They don't do that right now. They have their own electronic health record, but they're not really billing for those services. We plan to move them into Dr. Cloud as a part of the transition that we have moving away from NextGen. And so we'll be able to start billing for their services as well around the maternal child health work that they do in the SMILE program, very similar to what we do in Babies Born Healthy and our other maternal health maternal child program in public health. And so this will we don't necessarily see the dollars, and they go into general funds when they're returned, but it will, because we will now include that program, and it hadn't happened before, and all the data that goes with that, because now they are in the electronic health record, we'll have access to the data that we don't necessarily have access to now, or is easy access, because the data that we get comes specifically in reports from the vendor now. So we don't necessarily have access to the raw data. We have to ask. This will allow us, for our own internal system, since they're using that, for our data analysts to be able to access that and do all of the analysis and the things that we need.
So the liaison, sorry, I'd have to scroll up. Our liaison, you received the information from the contractor regarding data points. There's an internal system that the Department of Health and Human Services uses. Are you importing that information into the HHS system, or is it on paper in a drawer? Like, what's happening with the data that you're receiving?
No, it's not being imported. Because we weren't previously in the county EHR system. We are now just being set up in the system. So when I receive the data in the reports, that is as far as it goes, except for like my additional spreadsheets where I'm keeping track of like what's going on, but it does not get imported into county data systems now.
Okay, all right. And then, so I see that position, it says that it says $0. And so position isn't funded, how are we going to fulfill a position? So are we transferring a staff from somewhere out of AAHP to fill these 4 positions? Is that money coming out of AAHP's current contract?
Yeah, so there has been cost savings, underspending that has happened from the vendor the last 2 years. One, there is from last year, we know that there's $500+ that was left over in the purchase order that was not used. Looking at our third quarter analysis for this year, they're on a similar track to have to be underspent. Slightly looks like a little bit less than the 500,000, but still a significant amount. We also have some general fund program dollars that go to AHP generally, and so that are used for non-contractual programming. So there is possible savings there. So to fund these 4 positions, we would be taking money out of the contract and using the existing programmatic funds that we have now and converting them to personnel as needed to be able to address the cost of that. So that's why there's a $0 amount to this, because we're using existing funds that will, yes, remove some of the funding from the current contractor.
Okay, and then can you just clarify what specific programs, services, or staffing AHP was being paid for but was not implementing?
So I think that, so part of the underspend is there's been some staff turnover in the nurses, and so that creates a gap, so that reduces some of that. In addition, there was part of the fentanyl opioid awareness project that was not fully implemented. There's also a workforce development, there's a name for it, Leadership Montgomery is anyway, there was a workforce development program as well that was not developed or implemented. And then there was another program, I believe, called When I Get Out. Some of these are actually out of scope of the core services of the program, like workforce development. That is not part of our core services in the scope, and these were additions that were made maybe a few years ago. There have been a number of amendments to the contract over the years, and so we have been looking at right-sizing the scope, if you will, and also making sure that the scope is what we need it to be, and not just adding more services and adding and inflating. But that's an example. Those are a few examples of the things that were not implemented.
Okay, and then I know that this position is supposed to serve all 3 of the programs. Are all costing their funds here, or is everyone carrying over funds?
LHI will use all the funds allocated. Thank you.
Similar.
All of the funds are being expended?
Correct.
Okay, all right. And then who will the 4 DHHS staff be reporting to?
So the maternal health nurse lead will report to the manager 3. The data analyst, because of the way it's positioned, will, as Mark explained, it sits in Vantage, so that position actually reports to Dr. Nimhard, and then also we'll have a cross-reporting to me, the program manager 2, and then also the program specialist 2 will be reporting to the program manager 2 as well.
Okay, and then what additional steps is DHHS taking moving forward to ensure proper use of funds across all of our MHIPs is being done appropriately? How are we evaluating how funds are expended across all 3 programs moving forward?
So that's one of the reasons why we are where we are with the AHP at the moment, is because we have been looking at the trends in spending and what the needs are. So an internal evaluation of those dollars has led us to this point where we want to start with this transition to move some of these things internally to ensure that the funding is being spent. In addition, we know that the AHI, the Asian American Health Initiative, and Latino Health Initiative do their own internal audits and evaluations, as well as external evaluations on occasion, just to make sure. And I think that's in the plan for LHI next year to do an right. You're doing an evaluation of programs to make sure that, yeah.
We're doing continuous improvement on the programs, and every time we release a new RFP, we are making a concerted effort of the data that we're collecting, and specifically on the zip codes and on the level of service. And we do quarterly site visits and contract monitoring to ensure that they are providing the service delivery.
Right. And part of the reason why one of many reasons why we've tried to centralize all of the data within Vantage is to be able to provide a more centralized space to do these, to look at the data, to put things together that will allow us to make decisions based on the data. And so it's not just because the program has been going for 35 years, but that what was needed 35 years ago or 30 years ago, 1999, less than 30. 27. It's a long time. That we're actually looking at what the need was in 1999 is not what the need is in 2026. And so if we're still doing the same things, is it because we've just always done it and we don't want to change, or it's because that need is still there? And so we can have those anecdotal kind of conversations, but we haven't had the opportunity to necessarily dive in and look at it from a centralized viewpoint, especially because a lot of the data people have been sitting in the programs or in the service areas. They kind of are internal to that. By doing this, we have the broader picture. Vantage sits within my office, in the office of the Chief Operating Officer. We are, and Dr. Nemhard is part of our senior leadership team, so she's talking with all of the service area chiefs and the directors quite frequently. But this allows us to have an internal look at and make some decisions around what we're seeing in the data to make sure that we are, one, spending everything, and if we're not, why not? And what can we do differently with these dollars to address the current needs moving forward? So it has a larger scope. Vantage is a larger scope to it now than it has in the past, now that we're centralized.
I think it's, I'm glad you brought up these points, but I think the consensus at the last meeting in March, we wanted a standardized process across all three programs. And I don't think it's appropriate that a program is self-evaluating without a third party. These are tax dollars. And so if we are bringing in a data analyst that will carefully evaluate each of the programs, we need to standardize that process. And I think another meeting needs to happen with outlining what that process is going to be, what the criteria is, what the metrics are, and how often, how the information is going to be disseminated, and when the committee will get the reports before the next budget is approved. And so if I just had one more question about the LHI, because I see that there were two reductions for 151,000. Can someone talk about what's going on with the, I think this was for the language line.
Excuse me, can I just ask for clarity about the votes of the items? Are we just going to take a vote after the?
And then we can take a vote on each.
Okay, thank you.
Okay.
Thank you for the question. So we have this contract for the last 3 years, and there has been a consistent decline in the number of calls. Mm-hmm. So it's a parallel track. So in the current environment, people are not accessing services as much because they are afraid. So there had been a reduction in the number of calls for healthcare services and other services. There has been an increase on the number of food, but it doesn't make up for the number of overall calls that they received in the previous years. So there were an average of like 1,000, 1,100 calls a month, and now we are in the 600, 700, 800 calls a month. So it has been a steady reduction in FY26. But on the other side, there has been an increase on calls for the rapid response line. That rapid response line is not associated with the LHI current scope of work, because the current scope of work only provides services for referrals and information to Health and Human Services. So the need has changed, but the contract, the way that has been procured 3 years ago, does not respond to the emergent need.
Okay, so is this, are you resoliciting the contract or?
With a reduction of 151,000, we can continue for one more year, and then when the contract is recompeted, it will be readjusted. Maybe at that time there can be a conversion with the rapid response if there is an approval of the agreement of the amendment for the rapid response. This is a little bit what happened like COVID, right? There is emergent needs, and the community is afraid to be requesting services and is afraid to be involved with services. So they are not, there is a decrease overall of the numbers of people seeking healthcare services, people attending visits, even if it's virtual, public charge. There is a misconception that if you receive public charge, it will affect your potential immigration situation in the future. So that is related to what's happening to the health plan as the contract is as of right now. But in a separate track, we have the rapid response, the response to immigration questions, immigration rates, request for information, legal services. That is not part of the current contract of the LHI.
Okay. So services will not be interrupted.
No.
We are just, no longer need as
I'll
much.
just note there was mention of the rapid amendment from the executive that we were seeing that in context of the lighthouse, because that's where it lives. So I do appreciate the context and the comparison of the lines, but I wanted to make sure that the committee is informed about what is in the pipeline, if you can say, about discussions regarding the rapid response line.
Yes, and that's the next item. So if you can share a bit more about the Lighthouse initiative. I see that there's a decrease, even though the demand for services, housing, medical care, employment. So just wanted to better understand why these programs are seen as duplicative, and they are for our immigrant residents to support immigrant and non-immigrant services.
Please, just want to clarify, the rapid response line request is something different.
Yeah, I know.
So
The next one is the case management services.
Yeah. So both mentioned Lighthouse, but what I was talking about, we'll talk about next week when we discuss the Lighthouse budget. This narrative just says that they're utilizing this money, and it will, because there are Lighthouse services available. So I will let you talk about that.
Yes. Thank you.
Exactly to your point, the duplication of services. We are trying to avoid that. So the county has multiple case management services. The LHI case management service is through a vendor, and we provide Health and Human Services. We provide information and referrals, assistance for enrollment, to anything from food, through SNAP, to access to health services, to access to workforce training, to access to enrollment in English classes. But there is also, as an emergent need, a need for legal services and housing that is not contemplated in the LHI contract with the vendor for. The Lighthouse does have these two components of legal services. Have been working on steadily with the vendor, and also we are in constant communication with Lighthouse, is to provide the best care for our community when the client arrives at the vendor to do a triage pre-screening to identify the needs. If the family or the individual has legal needs or needs housing, they are going to be placed in the Lighthouse program.
Okay.
And if they have any other needs that have to do with food or housing, food or healthcare or enrollment for services, they will be served by the LHI case management services.
Okay, thank you. All right, so I recommend we restore the funding cut by the county executive. We're on the LHI initiative, the 537, 562, and add it to the rec list in 2 tranches of 268, 781.
Just for clarification, we are talking about item number 2.6 on page 29 of the packet.
Yes.
This is the reduction of 532. There is a recommendation that this amount be replaced back on the reconciliation list to add back in 2 tranches, split evenly of the 537.
Yes.
Okay. Is that a consensus of the committee?
Yes.
Okay.
All right. And the last, did you have?
So I do want to note that there was lots of discussion, but there was not a vote taking on items 2.1 through 2.4 as of right now.
Yes, there were still questions. Did we, for 2.5, are we, the 2.5, are we okay with the county executives? Okay, I'm fine. Councilmember Lukey, you're okay? Yes. Yeah, 2.5, we're okay with the county executive's recommendation, and then we will go back to the 2.1 through 2.4. I'm going to start with Councilmember Lukey. Did you have any questions? No. Okay, Councilmember Friedson.
Okay, I have just questions on, I concur with the county executive in general. I just do have questions on 2.3. Main question, seems like there's a big disconnect between the contractor and the department. It seems like this has been going on for a while. I'm just trying to reconcile the timing now, the adding of positions, and whether or not we don't fund the positions. I understand the thought process of adding positions in because your intention is to cut the contract or to use the funds that are currently in the contract for the positions. But are we being asked to fund the positions? Because this is the square that doesn't circle for me. You know, either we're being asked to cut the contracts and to replace them with positions in some form or fashion, and that could be like a half a position, and the contracts go through December 31st, and the positions start on January 1, or whatever the case may be, or there's a transition period, or we're not. But if we fund a position and we don't, or we create a position and we don't fund it, that position's not funded. So it's just confusing for me of how we can just move contract dollars to a merit position without appropriating dollars for the position.
I'll just speak from a budgetary standpoint. If you look at page 25, the DHHS does have a history of transitioning positions with $0 net change, meaning that they don't need any additional funds appropriated by the county to be able to fund those positions. So in the instance of number 2.3, there has been underutilization in the contract for the past 2 years up to $500,000, and other discretionary funding within the AHP dollars that are within the county that they will utilize to support these positions. So that is my understanding. And like I said, if you look at page 25, over the past years, they have shifted 23 positions from contract to merit with the net zero change. And so those are always a reduction within a contract. I'll say previously, for example, LHI, a majority of their staff used to be in the Primary Care Coalition contract. It made a way to add employees and go back and forth, but it was looked at that they needed to transition that model wasn't working for them to be able to retain staff. And so that's just one where like PCC recognized, and there was a vote of the committee that those dollars came out of the Primary Care Coalition contract, and they supported the LHI merit staff. So I'll stop there in terms of like,
Okay.
there's a historical.
Yeah,
yes,
we're running short on time. I do
Yes.
think there's a difference between transitioning a specific position from a contract to a merit. That's not really what we're talking about here. We're talking about changing the service delivery model, which I think is a laudable goal. I appreciate it. I'm just not sure I'm personally ready to create 4 new positions that I know exactly what they're going to do and how they're going to serve and where the funding is going to come from. There's a discrepancy on the $500,000 underspending that we try to understand that a little bit better, because there's, the invoice and the, that's been shared with us and the response from the department have been a little bit different. I'm not judging here to say that somebody's right and somebody's wrong, but I just think there's a lot of outstanding questions. So I'm personally, my view is, without prejudice of the decision that the department is looking to go in, I'm not ready to say yes to it. I feel like once we approve the 4 positions, then we've agreed exactly with the approach the department is recommending. I'm not saying no, it's a bad idea. I'm just not saying I'm not ready to say yes to it personally in this, situation, in this moment, because I think there are some outstanding questions. So my view would be to not support the 4 positions. I would like to have some flexibility to come back to this conversation when we're not compressed and already, over the time allotment. There's no lunch break for staff right now. We've already delayed the next committees. I don't think we're giving justice to anybody involved in this on the department side or on the contractor side to really delve into this. I think it requires a much deeper, much longer dive. So at this point, I'm not ready to say yes. I'm not necessarily saying no. I'm saying it's not the time right now from my perspective. So I am not supporting personally the adding 4 merit positions until and a better understanding of exactly the direction that I think we're going in.
Thank you, Councilmember Friedson, and we're going to turn it over to Councilmember Lutke for final remarks.
Well, I think we're done with that one. We are all in agreement on.
Well,
are we
I'm going to
not?
let you go there, and then I'll do both at the same time.
Okay, so the comments I was going to make, and my apologies, because they do not relate to this item. They relate to one we already took a vote on. So that's why I was saying we could go ahead and move forward with the AHP piece. But revisiting the Latino Health Initiative 2.6, I think it's important, given what the committee had said, to put it on the rec list, the money that was cut. There seems to be a bit of a disconnect in thinking that cutting this funding would cut legal services capabilities for our immigrant families, which is not true, correct?
Correct.
Okay. And so the recommendation that came over from the county executive's office to cut this is not because a whole thing is moving to another thing. It's just that the other thing, the Lighthouse Initiative, whose budget we take up next week, handles services of the type that LHI is referring over to the Lighthouse. So nobody is not going to get served by accepting the county executive's recommendation at 2.6. So if everybody wanted to have it on the rec list, that's fine, but it needs to be made very clear that nobody was losing something as a result of what the county executive had recommended at item 2.6 in the packet.
Correct.
Okay.
Correct.
That's all. I just want to make sure that gets clarified on the rec list so that at full council we can better understand that. Thank you.
All right, and so the final item was for AHP, item 2.3. I think the committee is all in agreement that we do not concur with the county executive's recommendation We want to have more information and can discuss it at full council and potentially a future meeting. Once we standardize the scope of all of our MHIPs and the evaluation as well, I think we will be able to better understand what transitions are necessary moving forward.
So just to clarify, when we come back before full council, there may, because Councilmember Friedson mentioned he had questions that wanted to be answered, but this wasn't the best time to be able to do that. There is a possibility that this could happen once those questions are answered. So when we come back to full council, we should be prepared to have that discussion.
Definitely. We can be. I can't speak for all of my colleagues, but I'm sure with more information, it would be helpful to be able to make a more informed decision at that time.
Because if the alternative is it's not going to happen, then we don't want to, I don't want to ask my staff to put together this big presentation and answer all these questions if the point is moot at this point because the committee has voted no on it.
Well, there's only 3 here, and based on the information that we have before us, we do not feel like we know enough about the current unspent funds or how these programs are scoped to respond to the needs and how the organization or contractors informed of what they are supposed to be doing. I've heard that they have received tasks that are outside of their scope. So for us to make a decision at this point, I don't think is a reasonable request. If we have additional information by the time full council meets, I think it would be helpful.
Okay, we'll be ready. Thank you.
Just for clarity, I will move through this
Go
quick.
ahead.
So for 2.3, there is a vote of the committee to not accept the county executive's recommendation. Is that a consensus, or is everyone? And I understand the other one. I guess outstanding is 2.1 and 2.2, if you want to put them together.
Yes.
3.5 FTEs for the AHI conversion.
Yes, without objection.
Of the full, okay, so approval of those. And then the only outstanding is I believe we're completed.
That was it?
Yes, we are
Okay.
completed.
And with that, we are adjourned. That's the final operating budget meeting. Thank you all for your patience and to be continued. We are adjourned.